On YouTube, are you getting, sir, any feed?
It should show that I'm live now. Good morning, everyone. We are actually now the NBFM is here today, part of the NBFM, which is our nerve blocks for the masses, workshop. Masses here mean for people who do not have access to ultrasound, and it doesn't mean that if just because you haven't got ultrasound, you can't give blocks, you can't provide good analgesia. Regional anesthesia or nerve blocks are important part of the multimodal analgesia as well for people who are having general anesthesia. It reduces the opioid requirements. It provides a greater patient satisfaction. They wake up pain-free, they're happy. So today we are going to cover the anatomical basis of the blocks. At the NBFM, which is in Surat on 2nd and 3rd, we will have live lectures, and on day 1, where we will talk about the blocks themselves. And on day 2, we're going to have live workshop, which will be two-way communication. People can ask their doubts. They can ask us to stop at any stage and clear their doubts and go back confidently to do these blocks. The blocks that can be done with just landmark using loss of resistance technique. Nerve blocks that can be done with using a peripheral nerve stimulation. So today program, we will start off from head to toe. So we will go through first with the head and neck blocks by Akhilesh, then brachial plexus by Anil, then abdominal blocks by Prasanna. Then we will have sort of lumbar and sacral plexus blocks, which are PNS guided blocks by Alka. And then we will end up with some, blocks of the ankle. In between, I forgot that we also have the thorax as well, which Akhilesh will cover, both the anterolateral, anteromedial, and the posterior blocks like your erectus spine A and the thoracic parietal block. So without much ado, I'm going to ask Akhilesh to actually start off with his, presentation on head and neck blocks. And if there are any questions, please post them on the chat box, and we will take those questions and come back to you. I think, unfortunately, today it's the cricket final as well, so a lot of people are waiting for that. But this video will be available on my YouTube channel, so people can go back and listen to them at any time. Over to you, Akhilesh.
Thank you, sir. So I'm sharing my slides, sir.
Yeah.
Is my screen visible, sir?
It is. It is. Go ahead. Go ahead, please. Go ahead.
Yes, sir. Yes. Yes. So good afternoon, everyone. Thank you, Shiv sir, for giving me this opportunity to present on this August platform. Also, I'd like to congratulate the team Surat for today only we got the news that almost 250 anesthesiologists have registered for the conference. So congratulations to the team. And I'll be presenting my first topic on head and neck nerve blocks and the anatomical basis. So let me start by sharing a small episode here that happened with me a few days ago. A few days ago, I was in a conversation with one of my old senior colleagues. I shared with her, we were talking about some regional anesthesia techniques and everything. So I shared with her that in the last week, I had done a couple of cases involving head and neck nerve blocks. One was a sebaceous cyst on the scalp, and another one was a lymph node biopsy from a Hodgkin's lymphoma patient. And then the response that I got was, oh, are there head and neck nerve blocks also? Or do we have nerve blocks for even head and neck? Because for ages, the nerve blocks always meant that nerve blocks means upper limb and lower limb nerve blocks. Maybe off late there was the stab block coming in and erector spinae, but it was the head and neck nerve blocks. Even today, people are somehow maybe ignorant or they don't want to attempt those, or maybe I don't know. Despite being the head being the epicenter of all the neurological activity, so I said yes, they are present, and so here we are in the head and neck nerve blocks. So why do we need to know about them? We need to know about them because they may be used as sole anesthesia techniques. They may be used especially in patients who are poor candidates for general anesthesia. They may be used as an adjunct to general anesthesia as well for perioperative pain relief. And if you are going to use, suppose, a fiber optic, so for facilitating airway access, we shall need these airway blocks. So even though, like I said, that head and neck is like a epicenter of all the neurological activities and a lot of nerves moving across, and a lot of blocks have been described for multiple nerves. But for all practical purposes, today I'll be dealing with the scalp block, the cervical plexus block, and the airway blocks under the headings of indication, anatomy with aspect to their origin and relationship with other structures, the landmarks that we should consider while administering these blocks, what are the procedures for giving this block in brief, the PNS guided and the landmark guided. What if you encounter failure? What can be the causes of failure? What are the complications that can occur? And how do we avoid or prevent these complications? Going on first to the scalp block. So what are the indications for scalp block? Scalp block may be used in neurosurgical patients for burr hole or for awake craniotomies. They may be used in plastic surgery for suppose some suturing or cyst excision. They may be used for short procedures in your ER and for acute and chronic pain management. Now, scalp block is not something like a single nerve block. It's a constellation of 5 or 6 nerves that need to be blocked simultaneously so that we get the most beneficial effects of these block. And if we see there are the nerves are supratrochlear nerve, the supraorbital nerve, zygomaticotemporal nerve, the auriculotemporal nerve, and the greater occipital and lesser occipital. Now these 5 or 6 nerves, they are located all across your scalp bilaterally. But what we do is we divide the scalp into the anterior scalp and the posterior scalp. Now, the anterior scalp is basically has been supplied by the branches of the trigeminal nerve, and the posterior scalp is being supplied by the cervical nerves or the cervical plexus. Moving on to the first set of blocks, that is the supraorbital or the supratrochlear nerves. These two nerves supply the forehead and the anterior part of the scalp. These two nerves arise from the frontal nerve, which is a branch of the ophthalmic division of the trigeminal nerve. Once this nerve enters the orbit through the superior orbital fissure, it divides into supraorbital and the supratrochlear nerves. And these nerves exit the orbit through the supraorbital foramen. The most vital structure that is associated with these two nerves, apart from the vessels, is the eyeball. Now, the landmark is supraorbital foramen, which each of us can palpate right on a supraorbital margin. And as we can see, what happens is we take a syringe with a 22 gauge needle. We go straight perpendicular to the skin at the site of supraorbital foramen. We hit the bone, we withdraw our needle by a millimeter or two, and then we make a subcutaneous wheal. We move further medially by 0.5 to 1 centimeter and make a similar wheel there. By this, we can anesthetize both the supraorbital and the supratrochlear nerve. Now, the common complications that can happen are one, damage to the globe. Two, intracranial injection can happen if we go very, very deep through this foramen. Third is ptosis, and fourth is the trigeminal cardiac reflex. Now, damage to the globe can be prevented. One, if we go from bottom to top approach, that is, the pointed end of the needle points cranially. Suppose you are going in the opposite direction, what you can do is, number one, first of all, counsel the patients that he should not move his head, because these blocks, even though they are superficial, they are extremely painful, and they may cause what is known as the trigeminocardiac reflex, which is vagus mediated reflex, something similar to the vasovagal response, and there is a hypotension, bradycardia, and rare cases asystole as well. So we should counsel the patient, we should be gentle, and we should always keep our atropine in hand, at least nearby, and keep talking to the patient. Another complication that can happen is ptosis. That is because these two nerves are associated with levator palpebrae superioris. And if a drug travels through this along with these nerves to this muscle, this can result into ptosis. So this is about the supraorbital and supratrochlear nerve. Next comes the zygomatico-temporal nerve block. Now, this nerve block is notorious for getting failed or being patchy. Why? Because it has got two components, a deeper component and a superficial component. This nerve arises from the maxillary division of the trigeminal nerve. It originates and then passes through the zygomatic bone. It lies in the temporal fossa, and following this, it pierces the temporalis fascia and the temporalis muscle and comes to lie superficially in relationship with the branches of the temporal artery. This supplies the temporal region and the forehead. And again, the common structures, vital structures associated with this nerve are the eyeball and branches of the temporal artery. So you can always expect what problems this can create if a needle gets malpositioned. The landmarks for this block are the supraorbital margin and the zygomatic arch. Now, what we do is we palpate the supraorbital margin, and at the lateral end of the supraorbital margin, we go further towards the zygomatic arch, around 1 centimeter, and we lie in the midpoint between the two. And we go perpendicular to the skin, and we go deep with a 22 gauge needle until we hit the bone, right? And at this point, we just withdraw a needle by a millimeter or two, and then we inject 3 to 4, 5 mils of local anesthetic solution. This is sufficient to anesthetize the deeper segment. And then gradually we come back to the skin and again raise the subcutaneous wheel. This will block the superficial segment. Again, the complications are almost the same. Trauma, because temporal bone is not a very, very strong bone, it's a thin bone. Two, it's possible to go intravascularly. And third is the trigeminocardiac reflex. Next nerve to be blocked is the auriculotemporal nerve. This nerve arises from the posterior division of the mandibular branch of the trigeminal nerve, and it supplies the temporal region and scalp above the pinna. It originates and it comes out of the cranium through the external artery meatus and the temporomandibular joint. So a landmark stays anterior to the ear 1 to 1.5 centimeter at the level of tragus and above temporomandibular joint. It is commonly associated with superficial temporal artery, and if we go deep, the facial nerve and the middle meningeal artery. So we should be cautious because there are a lot of neurovascular structures that are associated with this nerve block. And the causes of failure can be either parotid enlargement, which you can observe in chronic alcoholics or in obese patients, where you are just too superficial to infiltrate and the nerve isn't blocked. The complications again are deeper injections can result in facial nerve block or injury, or you can give the drug intravascularly. So you should always avoid deeper injections, and we should aspirate prior to injecting, be it any nerve block for that matter. The last two nerves in the scalp block are the greater and the lesser occipital nerves. The greater occipital nerve arises from the posterior ramus of the C2 nerve, and lesser occipital arises from the ventral ramus of C23. It is a part of the cervical plexus superficial nerves. The landmarks are the mastoid process and the occipital protuberance. And another landmark is the greater occipital artery. The greater occipital nerve arises and it runs along with the obliquus capitis and semispinalis capitis. It lies along with the occipital artery when it reaches the scalp. So pulsation of the occipital artery should serve as a guide to the nerve being blocked because it lies lateral to the occipital artery. The lesser occipital nerve originates and moves towards the scalp along the posterior border of the sternocleidomastoid. We will be able to see the nerve once I reach the cervical plexus. This nerve pierces the deep cervical fascia and lies on the scalp. Now, when we are administering the block, what we do is we join the mastoid process with the occipital protuberance, and then we divide this line into three equal segments. That is the lateral 1/3 and the medial 2/3, and the lateral 2/3 and the medial 1/3. Now, in the first case, that is lateral 1/3 and the medial 2/3, there lies the lesser occipital nerve, and the subcutaneous infiltration is fine to block this nerve. And when we go at the junction of medial 1/3 and lateral 2/3, we find the occipital artery pulsations, and to the lateral side of the occipital artery lie the greater occipital nerve. Here again we can subcutaneously infiltrate and block the greater occipital nerve as well. The common causes of failure are because since these nerve blocks are commonly employed in neurosurgical patients, poor identification of nerve blocks, landmarks, poor identification of the landmarks due to previous craniotomy scar, short neck, or sometimes the patients prefer not to get their head shaven. So there is always a possibility that you might mistaken these landmarks, and there might be a difficulty in infiltrating subcutaneously. Next, we move on to the cervical plexus block. And the common indications that have been mentioned are the first and foremost is the carotid endarterectum rectum. It has been mentioned across all the literature that this is one of the most common indications for which the cervical plexus block is being employed. Other indications are like central venous cannulation, thyroid and parathyroid surgeries, cervicogenic headaches, and clavicle surgeries, vocal cord surgeries, dental abscess, lymph node dissections, plastic repairs, etc., etc. So cervical plexus anatomy. The branches, cervical plexus gives rise to originates from C1, 2, 3, and 4. These four ventral rami form three loops. Sometimes a C4 to 5 loop may also be present. C1 anterior ramus is generally motor, and fibers from the C1 to loop join the hypoglossal nerve and supply the geniohyoid or thyrohyoid descendants muscles and form the descendants hypoglossi. Fibers from the descendants hypoglossi also supply the nerve to the superior belly of omohyoid. Descendants hypoglossi joins the descendants cervicalis from the C2 and C3 loops to form ansa cervicalis and supply the muscles sternohyoid and thyrohyoid and inferior belly of omohyoid. The branches of the cervical plexus can be communicating branches. C1, which gives rise to, which contributes to the hypoglossal nerve. C2 to the sternocleidomastoid. C3 and 4 to the spinal accessory nerve. Deep branches supply the neck muscles. and superficial branches or the cutaneous branches supply the neck, clavicle, and these are ascending branches are lesser occipital and greater auricular, and the transverse branches are transverse cutaneous nerve of the neck. So what lies under the skin? This is what we can see once we remove the skin. We can see the sternocleidomastoid, we can see the internal jugular vein, and we can see the superficial branches of the cervical plexus, forming the superficial cervical plexus. The landmark for the superficial cervical plexus block include the midpoint of the lateral border of the sternocleidomastoid. The relationship with vital structures include the external jugular vein. And to yield better results, we should either fan your local anesthetic and or give a field block kind of a thing. And secondly, we should always infiltrate in the midline to ensure that any crossover nerves are also anesthetized. Going on to the deep cervical plexus block anatomy. Now, in this, you can see that this is the diagram, and you can see that these are the muscles. This is the sternocleidomastoid muscle, and underneath you can see a green dotted line. And this green dotted line is the investing fascia of the neck, underneath which, when we deposit the drug, is the intermediate cervical plexus block. And this black dotted line is the deep cervical fascia, underneath which, if we deposit the drug, then it is the deep cervical plexus block. Variety of vital structures are associated with these blocks. That is the carotid artery and internal jugular vein in the intermediate layer, and epidural space and the vertebral artery in the deep. Now, how to give a deep cervical plexus block? The landmarks are mastoid process and the chestnut tubercle, which is the transverse process of the sixth cervical vertebra, posterior border of the sternocleidomastoid. So what we do is, sir, can I just change the power connection?
Yeah, that's fine. That's fine.
Am I audible?
Yeah, no rush, no problem.
Yeah, I'm fine, sir. Actually, that was running on my mind for some time. Okay, so what we do is the transverse process of the C6 is easily palpated behind the clavicular head of the sternocleidomastoid, right, at the level of cricoid cartilage. So what we do is we draw a line connecting the mastoid process to the chestnut tubercle. Once this line is drawn, C2, C3, and C4 points are respectively located on this line at 2 centimeter, 4 centimeter, and 6 centimeter, caudally to the mastoid process. Needle is inserted perpendicular to the skin at all these 3 points, or even a single level C3 or C4 injection is equally efficacious. Now, what we do is once we inject, we will first encounter the transverse process, right? We first encounter the transverse process, we hit the bone, and then what we do is we move our needle cranially by a millimeter or two every time, so that we and keep aspirating until we are completely off the bone. Because at this point, we are closely associated with the vertebral artery. And then when we are administering the drug or when we are off the transverse process, we aspirate well. We keep talking to the patient, because it can always happen that we are injecting a large amount of local anesthetic into the vertebral artery, which will reach directly to the brain and can cause sudden neurocardiovascular collapse for our patient. Stuck, I think.
Is it stuck?
Yeah, it's stuck.
Yeah, it's fine now.
Yes.
Yeah.
It's fine.
Go back one. Slide. Yeah.
Yeah.
I think it's moving forward.
Yeah. Sorry for the this glitch.
Cursor, so just go on to the left cursor on the thing. It's moving. Or stop sharing and then you can go start from the thing.
Yeah, it's going back.
One more, and I think one more after that. Yeah,
Yeah.
that's yeah.
Yeah. So we have covered the deep cervical plexus block, right? But one of the major problem with deep cervical plexus block is that phrenic nerve is closely associated with the deep cervical plexus block, because we had seen that our cervical plexus arises from C1 to C4, and C3, 4, 5 is the phrenic nerve. So it can always happen that when we give a deep cervical plexus block, our phrenic nerve can affect our diaphragm and we can have a diaphragmatic palsy. Now, in most of the patients who are young, it's okay to means it's transient and it recovers. But in patients who are respiratory cripples, cardiovascular, who are not really good, are having some cardiovascular disease, this can actually result into major respiratory distress and can complicate things. So we should be careful and we should be always on the watch out for any phrenic nerve palsy if it happens. The next is the intermediate cervical plexus. Now, this is an interesting block because if you see the older literature and older literature which has described the cervical plexus block, most of them have actually given intermediate cervical plexus block and have labeled it as superficial cervical plexus block. And there was a few days back, I think there was some query on the Facebook group as well, that is a single intermediate cervical plexus block sufficient, or should we give a superficial cervical plexus block along with it also? So the answer that was in the discussion, I read sir's response as well, that if you give yes, intermediate cervical plexus block alone is sufficient to block the superficial segments as well. And the landmark for this block are the same as that of the superficial segment, that is the midpoint of the posterior border of the sternocleidomastoid. But the difference is, in superficial cervical plexus block, we were actually infiltrating in the subcutaneous plane. Now, what we are doing is we are taking the needle, via blunted needle or a nerve block needle, and we are going perpendicular to the skin. At around 1 to 2 centimeter depth, we can feel a pop, that is of the investing fascia of the neck. And then here we deposit the local anesthetic 15 to 20 mils, and then we can do the surgeries like carotid endarterectomy. So the common complications include infection, hematoma, nerve injuries, epidural injections of subarachnoid block, local anesthetic toxicities, and phrenic nerve block. And how do we prevent them? We prevent them by aspirating prior to injections, avoiding deeper injections, and avoiding bilateral deep cervical plexus blocks, and always anticipating phrenic nerve palsies. Next, we move on to the airway blocks. Now, why do we need airway blocks is, one, we know awake fiber optic intubation. Another one is when we want to take an awake look in the airway. Now, awake fiber optic intubation, we might need to be doing oral awake fiber optic or nasal fiber optic. And this is the airway innervation, and the whole airway, right from the nose till the trachea, is being innervated by three nerves: the trigeminal nerve, the glossopharyngeal nerve, and the vagus nerve. The terminal branches of the maxillary and the ophthalmic division and anterethmoidal nerve innervate the nasal cavity. Now, these may be easily anesthetized by local anesthetic soaked cotton pledgets placed in the nasal cavity till the cribriform plate. You can even pack the nasal cavity with the local anesthetic. In real sense, then, we need actually blocks for glossopharyngeal nerve and vagus nerve. And the glossopharyngeal nerve supplies the posterior one-third of the tongue, vallecula, anterior surface of the epiglottis, walls of the pharynx, and tonsil. Now, if we don't block this nerve, the patient will probably never allow us to go to the oropharynx, because there will always be a gag reflex happening as the posterior one-third of the tongue is not anesthetized. And the common methods for this nerve block are: one, topical spray administration, nebulization, sprays. They are safe but less efficient. Then there is, we can directly place soap pledgets with LA on the mucosa. Again, they are also safe but less efficient. But direct infiltration by injection, either through the intraoral route or the peristyloid approach, they are the most effective way of blocking the glossopharyngeal nerve. So as you can see, there are two methods. One is the intraoral method. Other one is the extraoral method. Now, intraoral method, fine, we have to go in and behind the tonsils, we just have to inject with the needle. But the point is, we should have an adequate mouth opening, which is mandatory for the intraoral approach, right? So with the help of a tongue depressor, what we do is we depress the tongue, the anterior two-thirds. Then with a curved tip needle, we go in, and then at the base of posterior tonsillar pillars, we just move submucosally and administer 2 to 5 ml of local anesthetic. But we should be extremely cautious because the carotid artery is very closely, very closely associated with this nerve at this point, and we should aspirate prior to injecting. And to ensure patient cooperation, we can even topicalize the oral cavity or tongue prior to the block so that there is no movement of the needle while we are administering the block. Now, this is the extraoral approach or the peristyloid approach. This is interesting because what we do is we join a line between the mastoid process and the angle of mandible, right? At the midpoint, there's a sign gap between the two. So we just push in our finger with the non-dominant hand and we try to palpate the styloid process. Once we palpate the styloid process with our dominant hand, we take the syringe filled with local anesthetic and the needle and we hit the styloid process. Now we just reposition our needle to the posterior part of the styloid process. And again, we aspirate. Why? Because as you can see in this diagram, there are a large number of neurovascular structures that are associated with the styloid process. And these are the vagus, hypoglossal, and the accessory nerves, internal jugular vein, and the internal carotid artery. So any mistake can result in injury to any of these nerves or intravascular injection. Next, after covering the trigeminal glossopharyngeal, we move on to the vagus nerve blocks. Now, vagus nerve blocks, we have to block two nerves, that is the superior laryngeal nerve and the recurrent laryngeal. Superior laryngeal nerve has got two branches, the external branch and the internal branch. The internal branch of the superior laryngeal nerve originates lateral to the greater cornu of the hyoid. After originating, it passes 2 to 4 millimeter inferior to the greater cornu. And then it pierces the thyrohyoid membrane. Keep this thyrohyoid membrane in mind because when we are blocking this, if we do not go inside this thyrohyoid membrane, we will end up blocking the external branch of the superior laryngeal nerve, which innervates the dilators of the larynx. Also, it will give only a partial effect. Secondly, we should be beware of the carotid artery which is running nearby. Our internal branch of the superior laryngeal nerve innervates the base of tongue, posterior surface of the epiglottis, aryepiglottic fold, and the arytenoids. Superior laryngeal nerve can be blocked at the pyriform fossa, but reaching the pyriform fossa is again somewhat cumbersome. We need a lot of patient cooperation for that as well. And so external approach is what we all follow. It is easy and more comfortable. And with what we do is, with our non-dominant hand, we hold the hyoid gently because hyoid is a small, fragile bone. It can easily get fractured. And then with our dominant hand, we hit the greater cornu of the hyoid. We move inferiorly by 2 to 4 millimeters, and then we pierce this thyrohyoid membrane. And after aspirating, we inject the drug at this point. This will block our internal branch of superior laryngeal nerve, right? Moving on to the last nerve block, that is the recurrent laryngeal nerve block. I'm sure everyone has done this. And recurrent laryngeal nerve innervates or provides sensory innervation to the vocal cords and the trachea. The landmarks for this are the cricothyroid membrane. We should always, palpate the thyroid and the cricoid and then go to the cricothyroid membrane. Why? Because many people say that it is just 2 fingers above the suprasternal notch. This can be very, very misleading in short-necked people or tall people. It can vary. So we should not depend on such landmarks, and we should always palpate the thyroid cartilage and the cricoid cartilage to make sure where exactly the cricothyroid membrane is. Then what we do is we go perpendicularly from the at the inferior border of the cricothyroid membrane, because there is a vessel at the superior border of the cricothyroid. Then when we are in, we'll have a giveaway feeling. We aspirate and we get air bubbles, and then we inject around 2 to 4 ml of the local anesthetic solution. And we first instruct the patient that once we do that, you might get a vigorous cough. And once this rapid coughing is there, it's in a way helpful to us because it disperses the drug better. And what we get is a wonderful recurrent laryngeal nerve block. So that's all from my side. The forum is open for questions.
Oh, thank you, Akhilesh. That was a wonderful presentation.
Should I stop the sharing, sir?
Yeah, you can stop sharing now. On the chat, there's only one question, and that is from Dr. Menon. He's from Kerala. And he's asked, what is the relation of the superficial temporal artery to the auriculotemporal nerve? How close they're lying, or it lies posterior, anterior, anything specific, or it just a...
Not exactly specific, I must say, but it is something like the superficial temporal artery goes cranially from the external, from the temporomandibular joint, and it gives out a branch medially. Like if it is going like this, it will give a branch somewhere here. And this is where we are actually blocking the, I beg your pardon, sir, is it auricular temporal or zygomatico temporal that he's asking?
Asking about auriculotemporal.
Auricular temporal, right?
Anterior, yeah.
Yeah. So it is just near the superficial temporal artery, is just near the temporomandibular joint, and it is there. If we go, there's no as such relation that I didn't find anything, but just at the temporomandibular joint it's present, and we should aspirate prior to injecting. Not.
I think that's fine. I don't think there is any other question from anyone. But if a faculty any other faculty wants to add any point or want to say anything. Everybody is quiet, so I will likely I think move on to the next one. If people actually have any questions later on, we can actually start off. So next part is from moving from head and neck to the arm. So Anil will be discussing about the upper limb anatomy, the brachial plexus, and over to you, Anil.
Hello, everyone. Am I audible, sir?
Yeah, and your screen is visible as well. Go on.
Yeah, thank you. Hi, everyone. First of all, happy International Men's Day to all the men's in the group. So, I am Dr. Anil Kumar. I work as a consultant for a group called Bangalore Healthcare based in Bangalore. We provide anesthesia and ICU coverage to a few hospitals in Bangalore. So I would like to thank Dr. Shiv sir and Team Gujarat for providing me this opportunity to deliver this lecture on upper limb anatomy. So before going to the topic, I would like to thank my good friend Dr. Hitesh for providing me a few of his videos which helped me in this topic. I have used animations from an app called Complete 3D Anatomy on iOS platform. Images I have borrowed from Google and Nisora, and I'm very thankful to Dr. Shiv Kumar sir to go through this and edit this PPT. So this will be my overview of the lecture. Let us straight away go to the brachial plexus anatomy. So let's start with the basics. This is a simple line diagram to enumerate the brachial plexus. So brachial plexus is formed from anterior, let me use the pointer. Okay. Brachial plexus is formed from the anterior nerve roots from C5 to T1. So the C5 and C6 join to form the superior trunk. The C7 continues as the middle trunk. C8 and T1 forms the lower trunk. These trunks divide into an anterior division and a posterior division. The posterior division of all this trunk, highlighted in this diagram as pink color, join to form the posterior cord. The middle and the superior trunk anterior division join to form the lateral cord. The lower part, anterior division from the lower trunk, continues as the medial cord. From the lateral cord, the branches which arise is the musculocutaneous nerve. From the posterior cord, the axillary and the radial nerve arises. From the medial cord, the ulnar nerve arises. A pec from lateral and the medial cord join together to form the median nerve. There are other branches in this brachial plexus. The dorsoscapular nerve arises directly from the C5 nerve root. C5, C6, C7 nerve root join to form the long thoracic nerve. The suprascapular nerve arises from the superior trunk. From the lateral cord, the lateral pectoral nerve arises. From the medial cord, the medial pectoral, medial brachial cutaneous, and the medial antebrachial cutaneous nerve arises. Let's look at an animation to better understand the brachial plexus block and where exactly we are giving the brachial plexus block. As discussed earlier, the brachial plexus arises from the cords from C5 to T1, the anterior rami. The posterior rami, discussed previously by Dr. Achilles, supplies the posterior part of the neck. So, if we superimpose onto here, where we relatively perform these blocks, the interscalene block is performed at this level. At the trunk level, there is an advanced ultrasound-guided block that is called as a superior trunk block, which can be delivered at this level. Then on to the divisions, we perform the supraclavicular block at this level. This is just above the clavicle. Underneath the clavicle, the cords arise. As you can see here, the cords are named to its relationship with the axillary artery. So the lateral cord is lateral to the axillary artery. The posterior cord is posterior to the axillary artery, and the medial cord is medial to the axillary artery. And these cords are present below the below the clavicle. And this is where we consider giving the infraclavicular block. So to summarize, the interscalene block is given at the roots, supraclavicular at the level of divisions, infraclavicular at the level of cords, and the axillary artery where we give the terminal branches of the brachial plexus. So which blocks to consider? I'll be more or less telling you about the block dynamics. I mean, I will not be considering the details of the block because that will be dealt in the live lectures at Surat. So my topic will mainly cover which blocks to give to which type of surgeries and what will happen to each kind of blocks. So let us start with the interscalene block. So interscalene block at the roots, this is a fantastic ultrasound image where we can clearly see the C5 to C8 nerve roots lie in between the middle scalene and the anterior scalene in the interscalene groove. And this Nisora image depicts very well that when we give an interscalene block, it is mainly for the surgeries involving the humerus or the upper part of the arm. And majority of the surgeries involving the shoulder it is better to consider the interscalene block. So what is an ideal response? Here, Dr. Hitesh has fantastically demonstrated the ideal response, what we can expect from the interscalene block. As you can see here, we are seeing the deltoid or a pectoralis response. So this is an ideal response. So what happens if you are getting, say like a scapular contraction? So that is because your needle will be somewhere in the middle scalene, and this is the dorsal scapular nerve which you will be stimulating. So you'll have to readjust the needle. The details will be dealt in the Surat lectures. So coming to the supraclavicular block. So as you can see, the supraclavicular block, this is a fantastic, again, a fantastic ultrasound image where you can see a typical bunch of grape appearance. Now you know why we see the bunch of grape appearance, because of the presence of divisions of the brachial plexus. So, and this Nisora diagram also depicts why supraclavicular is also called as the spinal of the upper limb. Most of the surgeries with the upper limb can be anesthetized or use an analgesic with the supraclavicular block. And this is why we should and must know how to give a supraclavicular block. Next, when we see the ideal response from the supraclavicular block, and as we go distally from the cords to the trunks and divisions, we should be aiming at as distal of a response as possible. Here we can see that we are getting the finger extension and a response at the wrist level. So this is an ideal response where we should be, which we should be aiming for when we are giving a supraclavicular block. So coming to the infraclavicular block. So as I mentioned earlier, you can see the nomenclature of the cords is based on its relationship with the axillary artery. As you can see, the lateral cord lies lateral to the axillary artery, posterior cord lies posterior to the axillary artery, and the medial cord lies medial to the axillary artery. And also you have to notice that the posterior cord is the one which is important to be sure that the infraclavicular block is working. Because if the needle is at the lateral or a medial cord level, you could be getting a contraction of the pec muscle. That means your needle is somewhere over here. So you'll have to go more deeper and try to get a stimulation of the posterior cord. So the infraclavicular more or less similar to the supraclavicular. So the infraclavicular is also proven block, which will help in anesthetizing or providing analgesia to major surgeries of the arm and forearm. So what is an ideal response? As I said previously, we should start getting as distal response as possible. Here, again, an excellent demonstration by Dr. Hitesh, where we can see he is getting the stimulation of posterior cord. See, posterior cord gives the radial nerve. So this is a fantastic radial nerve response which we are getting. Next, at the axillary. Now we come at the axillary level. This is an important animation or a diagram which will help us better understand the axillary level and nurse how it is related to the axillary artery. As you can see here, the median nerve lies very close and just superior to the axillary artery. And the musculocutaneous nerve also lies above, but it is little far away from the axillary artery. And two nerves lie below the axillary artery at this level. One is the radial nerve, and next is the ulnar nerve. So what is also important is the presence of an axillary sheath. The axillary sheath covers all the nerves except the musculocutaneous nerve. So this is an important landmark and very important structure you must consider while giving an axillary block. I'll tell you why it is important in the further slides. As you can see here, as I discussed previously, the musculocutaneous nerve here, this is an ultrasound image, it will lie between the biceps and the coracobrachialis muscle. And it lies outside the axillary sheath, highlighted here in blue. Around the axillary artery, the median nerve lies just above the axillary artery. The radial nerve lies below the axillary artery. The ulnar nerve can lie above or just below the axillary artery, and it is more posterior. So when we are giving an axillary block by PNS approach, we direct first needle, we direct towards the musculocutaneous nerve, that is at an angle of 45 degrees. Two injections are given. One is two injections above the axillary level to anesthetize the musculocutaneous nerve and the median nerve, and two injections below, that is radial nerve and the ulnar nerve. So at an angle of 45 degrees, we'll get a contractions of the musculocutaneous nerve. At a more acute angle, almost parallel to the axillary artery, we get the musculocutaneous nerve contractions. So when we direct the needle below the axillary artery, we'll be getting the contraction. We should aim for contractions of the radial nerve. You may or may not get an ulnar nerve response because, as I discussed previously, all these nerves are within the axillary sheath. When giving either a median nerve or a radial nerve, your drug spillage might have blocked the ulnar nerve. So you may or may not get an ulnar nerve response. So you should not repeatedly poke for getting an ulnar nerve response. So that is why you should know this anatomy. So let us have a look at other major nerves of the upper limb. Let us go one by one. So first starting with the musculocutaneous nerve anatomy and its response. The musculocutaneous nerve arises from the lateral cord and in the axilla gives supply to the muscle called as the coraca brachialis. But most importantly for us, it gives off a branch to the biceps brachii and brachialis. Musculocutaneous nerve runs inferiorly and gives and continues as the lateral cutaneous nerve of forearm, which supplies the anterolateral part of the forearm. So let us look at the musculocutaneous nerve response. So I have done a dual guided technique. I'm stimulating the musculocutaneous nerve by ultrasound. As you can see, because it supplies the biceps muscle, so contraction of the biceps causes flexion at the elbow level. So this is the response you should aim while giving the musculocutaneous nerve block. So coming to the median nerve. So the median nerve lies very close to the axillary artery or the brachial artery. And then in the forearm, it gives majority of its nerve supply to the anterior, that's the flexor compartment of the muscles of the forearm. And then at the level of hand, it gives of supply to the muscles which are involved in flexion of the fingers. So when we give the median nerve, as I said, at the axillary level, it is closely associated with the axillary artery and just lies along the axillary artery. So when we stimulate the median nerve, this is the typical response which we can expect. Here, we can see that there is contraction of the fingers of the hand, which is causing flexion at the fingers and flexion of the wrist. This is a median nerve response. So let us now go ahead and learn about the ulnar nerve anatomy. The ulnar nerve lies behind the brachial artery, runs down into the arm behind the medial epicondyle of humerus, and gives off a branch to the flexor carpi ulnaris and part of the flexor digitorum profundus. But most importantly, it gives off supply to the adductor pollicis. So the end branch of ulnar nerve is also called as the graveyard of the ulnar nerve. So the branch to the adductor pollicis is also called as the graveyard of the ulnar nerve. So this same principle is used in the neuromuscular monitoring as well. When we place the leads along the ulnar nerve, so if we get the stimulation of adductor pollicis, you are 100% sure that you are stimulating the ulnar nerve and nothing else. So ulnar nerve is basically given at the level of forearm. I'll tell you why we choose the forearm. This is the typical ulnar nerve response. As you can see, this is the contraction of the flexor carpi ulnaris, and this is what I meant. This is the adduction of the thumb. This is a typical response. If you get this response, this is for sure that you are stimulating the ulnar nerve. The radial nerve is an important structure as well. The radial nerve gives off majority of the branch to the posterior compartment of the arm and the extensor compartment of the forearm. It has two divisions which will divide at the level of elbow into one is the superficial radial nerve branch, another one is the deep radial nerve branch. When stimulating the radial nerve, this is the response we should expect because it supplies muscles of the posterior compartment or the extensor compartment of the forearm. We get extension of the fingers and the extension at the wrist. So this is an ideal response for the radial nerve. So to summarize, this will be the median nerve response, that is flexion of the fingers and flexion at the wrist. Musculocutaneous nerve will be flexion at the elbow, that is because of the stimulation of the brachial, the biceps brachii. Ulnar nerve will be stimulation of the adductor pollicis that will cause adduction of the thumb and ulnar deviation of the ulnar deviation at the wrist. The radial nerve response will be one of extension of the fingers and at the wrist. Now let us look at the ulnar, the nerve arrangement at the level of elbow. When we remove the skin and subcutaneous tissue at the level of elbow crease, this is the arrangement of the nerves at the elbow. As you can see that the radial nerve here, most lateral part, is already divided into a deep branch, which is a motor branch, and the superficial branch, which is a sensory branch. So when you are giving the radial nerve branch, it is better to give just above at the level of the elbow to get a PNS response. And at this level, the median nerve just lies very close to the brachial artery, just few millimeters besides on the medial side. As you can see here, the ulnar nerve lies behind the medial epicondyle of the humerus. And we can actually give the ulnar nerve block here, but it is very painful for the patient. That is why we prefer giving the ulnar nerve block, a rescue ulnar nerve block at the level of forearm. So let us now discuss the arrangement of these nerves at the level of wrist. Starting with the ulnar nerve. So ulnar nerve, we can see the important landmark of ulnar nerve at the wrist is the palpation of the flexor carpi ulnaris muscle. So after palpation of the flexor carpi ulnaris, the needle is directed more underneath the flexor carpi ulnaris to stimulate the ulnar nerve. Most important structure here is the ulnar artery. So you should aspirate before giving the drug. So this is how you give the ulnar nerve block at the level of wrist. Both landmark as well as the PNS you can utilize at this level. So coming to the radial nerve here, as you can see, we are actually giving the superficial branch of the radial nerve block. Because as I mentioned earlier, the radial nerve is already divided into a superficial branch, which is which has cutaneous innervation, and a deep branch, which has the motor innervation. That is why when we give a superficial branch of the radial nerve, this is only for the cutaneous innervation. We cannot use a PNS at this level. So first we mark for the radial styloid process, and we go 3 centimeter proximal, and we give a fan-shaped infiltration at this level, because there are numerous branches of superficial radial nerve here. Most important structure here to note is the radial artery. The radial artery pulsations can be felt, and it is best avoided by aspirating before injecting the local anesthetic. So this is the radial nerve. Coming to the median nerve at the level of wrist. So first at the level of wrist, first we mark the wrist crease. And after marking the wrist crease, when we see what is lying underneath the skin, the two important tendons we should consider while giving the median nerve block. One is the palmaris longus tendon, and another one is the flexor carpi radialis tendon. So that the median nerve lies in between these two tendons only. So from the wrist crease, a 0.3 centimeter is taken above the wrist crease, and we have to puncture the skin subcutaneous tissue, and we have to give around 3 to 4 ml of local anesthetic. We can also attach a PNS and get a median nerve response over here. So we have to discuss what are the missed segments. As you can see in this diagram, that medial brachial cutaneous nerve and the medial antebrachial cutaneous nerve are responsible for covering the medial part of the arm and the anterior medial and the anterolateral part of the forearm. And also to consider is the intercostal brachial nerve, which has a small cutaneous nerve supply in the inside of the axilla. So where exactly do we consider giving these blocks? So as you can see in this fantastic ultrasound image, that all these nerves, the medial antebrachial cutaneous nerve, medial brachial cutaneous nerve, and the intercostal brachial cutaneous nerve are all lying in the subcutaneous plane at the axillary level. So that is why a simple subcutaneous infiltration at this level will cover most of these nerves. I came across a study where they did a study where they have identified that this part of the hand highlighted in yellow has, in spite of a good median nerve, radial nerve, and all those previously mentioned nerve blocks, this part of the uh, uh, hand is not supplied by any of the nerves. So that is why it is very important to give a subcutaneous infiltration if you have pain around this area. And that is why the brachial plexus anatomy and the nerve blocks are still a mystery. So how do we test the blocks after we give the injections? If the patient is unable to push against the resistance, this is because we have blocked the triceps, which is supplied by the radial nerve. So this tests the efficacy of the radial nerve. And if the patient is unable to pull, this means we have given a very good musculocutaneous nerve, because musculocutaneous nerve will give a supply to the the biceps brachii muscle, and hence the patient is unable to pull against resistance. And to test the median nerve and the ulnar nerve, if we use a pinch test at the median border and the ulnar border, we can very well know whether the block is working or not. So to summarize, we have to know the surgical site and the block corresponding to the dermatomes, myotomes, and osteotomes. Distal surgery required distal blocks, and hence, if we use the distal blocks, there will be quick onset. Missed segments need to be covered with LA infiltration or by rescue blocks. Know what response to look for. Know how to check blocks, especially for awake surgeries. Thank you, one and all.
Thank you, Anil. I think that was a great lecture on whole of the brachial plexus, and I think every postgraduate student should actually listen to these lectures. And Akhilesh, I think there are a few nice comments for you in the chat section. That's an excellent presentation. There weren't any questions for you, Anil, but there are actually
Yes.
few, I think, remarks I would like to actually make about brachial plexus, especially related to, I think, supraclavicular. Our understanding is changing, and it is interesting that people tend to have on a partial block with ultrasound more so than when it was done with just landmark technique, wherein people actually just went with a needle, hit the rib, and gave that. And that actually now we are able to understand, even though you showed the picture of the brachial plexus in the supraclavicular area as grapes, actually they are not. They are actually in bundles, as they divisions are going to form the your cords, infraclavicular cords. You can actually see them as a bunches, which is going to form the medial cord, posterior cord, and the lateral cord. And they're lying around the artery. So superior to the artery, you got those divisions which are bunched up, and within the connective tissue. So those are some of the bunch of grapes you actually look at. And with the higher frequency probes now we can actually see that very, very clearly. And so you have the posterior cord, the divisions which form the posterior cord lying in the so-called the corner pocket. And that's why people used to try to actually get to that and miss out. And previously we were saying that, oh, don't try to actually go between these divisions, the bunch of grape, because you can cause harm. Now it's the other way around. It said that you can actually see this connective tissue, you can go between the connective tissue, so you can go between the bunch of grapes that forms the medial cord and the lateral cord, go in and deposit local anesthetic around that. So I think going and trying to get the posterior response is very, very important. Getting the radial response is very important in that. So that was in terms of the supraclavicular. But infraclavicular, you talked about the axillary sheath, or also some believe that there is cervicoaxillary fascia. But cervicoaxillary fascia, some people believe in it, some don't. I have seen it while giving the interscaling. You can actually see it nicely, just like you get a paraneural sheath in the popliteal fossa, similarly in the supraclavicular area. But what is more important is, as you actually go infraclavicularly, what has been seen that there is actually a septum between the lateral cord, and the medial cord and the posterior cord lie below the septum. So there is a clear demarcation, and it can be seen on ultrasound very clearly. So when you are going for the posterior cord, yes, you deposit local anesthetic there, but also come out and deposit local anesthetic on the lateral cord, so both. And that gives you a good block. So how does it correlate to a landmark guided technique or PNS technique? Now, you would have actually seen there's something called two-needle technique, which was demonstrated in Mumbai, where you actually went in and deposit local anesthetic, and it was there, and then you actually come out and do that. People do that. There was transfixation technique described where they deliberately went through the artery, deposited local anesthetic posteriorly, and came out deposit, and really worked well. You ask people who do that technique, and they say it never fails. And the reason is because then you are actually going beyond the septum and away from the septum. Okay, it's not that there is actually septum around each of these cords. It is actually just dividing this. So you have got a little cord lying above, and you got the medial and the posterior cord lying below the septum. So injection. So even if you're doing the, say, VIV block or thing, you go get the posterior response, okay, radial response, come out and inject a little bit of local anesthetic as you're coming out. So always do that. Don't expect that you are actually going to get an overspill with that. And same thing with the axillary approach. So infraclavicular block is nothing but giving axillary block at the apex of the axilla. Axilla is a pyramidal shaped structure which opening into the supraclavicular fossa. So you are infraclavicular, just it's a proximal axillary block. When you're going into the base of the axilla, where you actually give the actual axillary block, that is on the base of the axilla. So that is the lower axillary block. And you got the subcoracoid block, which if we, in the live lecture, we'll try to demonstrate that. If we get a patient, we'll demonstrate that. I think that's it. I don't. There's someone actually has mentioned, SM Arman has actually mentioned about the same thing what I was talking about. Yeah, that I think I've answered that question which was asked about the septum. So that that is very, very clear. So the septum does exist. I have seen it. I have videos of that. Yeah.
Previously, when we used to give ultrasound guided block, it always at the supraclavicular level, it always used to be an in-plane approach. Now we are more comfortable giving an out of plane because of the presence of these sheets.
Now we can give it in line. I've given in line. So I think out of plane, you're more likely to go between the your bundles. I was talking about the connective tissue, which is forming the medial cord and those forming the lateral cord, and then you actually going in between with the out of plane approach. But you can do that with in plane approach as well. I always use in plane approach. It's possible to do that, so it's not difficult to do. But yes, out of plane. I mean, on the continent, European guys, they tend to love to do out of plane approach.
Mm.
And a lot of their blocks are actually out of plane. So that's to do with ultrasound, which is another topic on itself. But
Yes, sir.
I think what you're doing when you are doing a landmark technique using, just a needle, that's what you're doing. It is like an out of plane approach.
Yes, sir.
And you are actually going. And that's why I think they are a lot more successful than inline approach. If you don't get local anesthetic to the posterior cord, you're not going to get that.
Yes, sir.
So each of them has got a septum. So that's what it was that supraclavicular. As they're forming, the medial cord has got its own connective tissue. That's one. Lateral cord's own and posterior cord. They all actually have their own compartments, kind of thing. And it's very, very. I've got a beautiful picture of that. I think it was published in RAPM, which I could have actually shown that. But yeah, I think we would.
Can I
That
add
is
one more?
the day.
Can I add
Yeah.
one more point,
Yeah,
sir?
yeah.
Because I have observed at the level of elbow, in spite, if it's a complex elbow, it is
Yeah.
always safer to give at 2 levels. Is it right, or what do you opine, sir?
Yeah, so that is a very, very interesting point, that if you are actually, people say that supraclavicular block is the spinal anesthesia of the upper limb, but still when you're actually operating on the elbow, and you'll see no, as they go on the medial side, the patient will always, and that's because you, even though we consider the intercostal brachial nerve and medial cutaneous nerve of the arm as the cutaneous nerves, these nerves cross the joint and they actually do give branches to the joint. So when you're doing the supraclavicular block, you miss them. But when you're actually using the infraclavicular block, you will see that local anesthetic actually seeps onto that plane. It's like giving your pectoral block. And it does block your medial cutaneous and intercostal brachial nerve. And intercostal brachial nerve and medial cutaneous nerve of the arm have an inverse relation. What it means is that one can be more dominant than the other.
Yes, sir.
So if intercostal brachial nerve is the major nerve, it will be bigger, and the medial cutaneous nerve of the arm is smaller. And it could be other way around. You can have smaller contribution from they go and meet in the arm. Okay. And both these nerves need to be blocked for complete analgesia for the elbow. So if you are thinking of that, yes, you can combine it. It's not a problem. But I would actually go for an infraclavicular block. But if you're going for the supraclavicular block only, or for whatever reason that the patient obese and things like that, go and put some local anesthetic into the base of axilla, like you do a SAP block. And that will actually take care of your intercostal brachial nerve and the medial cutaneous nerve of the arm as well.
Thank you, sir.
So, excellent, guys. I mean, these two lectures were fantastic. We have already exceeded 300 views. We are on almost 329 views. So, excellent, well going. So from the upper limb, so we've done the head and neck, we've done the upper limb. We'll move on to the lower limb plexus, which will be the lumbar and sacral plexus. And Alka is actually going to take us through that. So she will continue both. These were supposed to be 2 lectures, but she's going to give us both the lectures on lumbar and sacral plexus. Over to you, Alka. We can't hear you. I think you're still muted. Yeah. Yes, you're visible and you're audible as well. Go ahead.
Everyone. Today let's talk anatomy for the lumbar plexus block. Myself, Dr. Alka Booth. I'm a consultant anesthesiologist in Surat at Diamond Hospital. So we'll have a look at the formation and location of the plexus, the branches that arise from the lumbar plexus, what are the surface landmarks, how to approach the plexus, what should be the ideal response on PNS, what if you don't get the ideal response, how to troubleshoot, and some tips for the same. So these are the lumbosacral plexus. We can see here. What are the nerve plexuses? So basically, the nerves that supply directly, do not supply the organs directly. The ventral rami of some nerves, spinal nerves, they form plexuses. They branch and reanastomose and then supply the organs. According to the location, they are the
Sorry,
cervical
Alka.
plexus. Yes, sir.
Okay, if you switch off your video part, because I think your voice is not as clear and there is some slight disturbance. So just switch off your video. No, not the presentation. So if you look at the camera on the thing, switch off the camera.
1 second.
When you actually have the mic and the camera, so switch off the camera and then start and see, you might actually get a better, yeah, that's it. Switch off the camera so you're not visible.
Okay now, sir?
No, you're still visible. Switch off your, on the thing, you have the mute and the start video thing. On the start video, just switch off the video, like you can't see me, yeah.
Is
And
it
then
okay?
go to, yeah, that's fine. And then go on to the presentation now.
Okay.
Slideshow.
Is it okay?
Yeah, that's fine.
Okay. So according to the location, we have the cervical plexus, lumbar plexus, sacral, and okay, the plexuses. So let's have a look. How is the lumbar plexus formed exactly? So here we can see this is the spinal cord, which gives off the dorsal and ventral root, which will combine to a dorsal ramus and a ventral ramus. So this ventral ramus is what will form the plexuses. So at the level of first, second, third, and fourth lumbar vertebra, the spinal nerves will combine to form the lumbar plexus. Here we can see simplified version. So what are the branches that come out? So the spinal nerves will again divide into ventral and dorsal division. So the upper division of the L1 will give off the iliohypogastric and ilioinguinal nerve. The lower division of L1 will combine with the upper division of L2 to form the genitofemoral nerve, whereas the ventral divisions of L2, 3, and 4 will combine to form the obturator nerve, whereas the dorsal division of the same levels will form the femoral nerve. The lateral cutaneous nerve of thigh is formed from the dorsal division of L2 and L3. L4 and L5 will combine to form the lumbosacral trunk, which will descend down and take part in formation of the sacral plexus. So these are the branches of the lumbar plexus. The main branches are the femoral nerve, obturator nerve, and lateral cutaneous femoral nerve of thigh. Others are the inguinal, hypogastric, and genitofemoral nerve. Let's have a look at them in detail. Okay. So the femoral nerve, it is the largest nerve of the plexus. It arises from the dorsal branches of L2, L3, and L4 nerves. It will, after formation, it will emerge from the lateral border of the psoas major and sandwich between the psoas major and the iliacus muscle, and it will enter the thigh under the inguinal ligament and deep to the fascia iliaca muscle. What are the branches of the femoral nerve? It's a mixed nerve. It will give off articular, motor, and cutaneous branches. Let's have a look. So the femoral nerve, after entering the thigh, will divide into the posterior and anterior divisions, and articular branches will be given off to the hip joint and knee joint. So if any surgery are involving these joints, we obviously have to block the femoral nerve. Next are the motor branches. It will give off branches to the muscles in the anterior compartment of the thigh, namely the quadriceps muscles, that is the vastus lateralis, intermedialis, and vastus medialis, along with the rectus femoris. So these quadriceps muscles are involved in all the activities like walking, running, etc. So any block of the femoral nerve, whether it is desired or undesired, it will block this muscle and obviously hamper the activities. So particularly in those cases where the surgeon wants early mobilization, we have to be careful in selecting motor sparing blocks, which spares the femoral nerve and the motor branches to these nerves. Other branches are to the iliacus, nerve to pectineus, and sartorius muscles. Next are the cutaneous branches. So the anterior division of the femoral nerve will supply the anteromedial part of the thigh via the intermedial and cutaneous nerve of the thigh, and the posterior division of the femoral nerve, it will give off an infrapatellar branch to the knee. As the name suggests, it supplies a patch on the patella, skin over the patella, and it also takes part in forming the prepatellar plexus. Next is the saphenous nerve. It is the terminal branch of the femoral nerve. It's purely cutaneous. It will supply a thin strip of area on skin on the medial side of leg as well as foot. As we can see here, this yellow patch over here, it is supplied by the saphenous nerve anteriorly and posteriorly. So any surgery involving these areas, we have to block the saphenous nerve in surgeries like debridement of diabetic foot, etc., or K-wire of the lower limb. Next is the lateral femoral cutaneous nerve. It arises from the dorsal branches of L2 and L3. It supplies sensory innervation to the lateral portion of the thigh, as the name suggests. It's purely cutaneous and supplies the lateral area. So after arising, it will emerge on the lateral border of the psoas muscle and cross the iliacus obliquely. Then it will approach the anterior superior iliac spine. It will enter the thigh under the inguinal ligament 1 centimeter medial to the ASIS. However, this course is not uniform. It has many anatomical variations. As we can see here, it can be prefixed as well as postfixed. The origin can vary. Also, the course can vary according, like it can, it does not always go under the inguinal ligament. It may go over, through, or over the or through the sartorius muscle also. Here we can see the area, the purple area. It is the dermatomal supply of the lateral femoral cutaneous nerve. So any surgery which involves this incision over this area, example the femur surgeries, we have to block this nerve for analgesic purpose. Next comes the obturator nerve. It arises from the ventral branches of L2, L3, and L4. It supplies the inner part of the thigh. Here we can see the blue area. It emerges from the medial border of the psoas major muscle at the pelvic brim, and then it enters the thigh via the obturator foramen and then divides into anterior and posterior branches. What are the branches? So articular branches, motor and cutaneous. The articular, it will give an articular tweak to the hip joint and to the knee joint as well. So any surgery involving these joints, that is the hip and knee joint, we have to block the obturator nerve as well along with the femoral nerve. Next are the motor branches. It will supply all the anterior muscle. It will supply all the adductor muscles of the thigh, that are the adductor brevis, longus, gracilis, and adductor magnus. Along with it will also give a branch to the pectineus and obturator externus muscle. Next are the cutaneous branches. So it will supply a skin on the medial aspect of the thigh. Here we can see this is the medial part of the thigh that is supplied by the obturator nerve. Next are the smaller nerves, that is the iliohypogastric nerve. It is formed from the T12 and L1 spinal nerves. It supplies the lateral gluteal area and motor innervation to the abdominal muscles, that are internal oblique and transverse abdominis muscle. Next, the ilioinguinal nerve. It is a branch only arising from the L1, supplying the anterior and superior and medial parts of the thigh, supplying the same muscles, that is the internal oblique and transverse abdominal muscles. Next is the genitofemoral nerve, which arises from L1 and L2. It has two components, that is the genital branch and femoral branch. Genital branch supplies the cremaster and scrotal skin and mons pubis and labia majora in women. The femoral branch will give sensory innervation to the anterosuperior part of the thigh. All these three nerves, that is the ilioinguinal, iliohypogastric, and genitofemoral nerve, we can block them for any inguinal surgery, especially open inguinal hernia repair. We can block the genitofemoral nerve has to be blocked at the deep inguinal ring by the surgeon by giving local infiltration. So now that we have looked the branches in detail, let's have a look at the surface landmarks, how to approach the plexus. So what are the landmarks for the lumbar plexus block? The patient here is lying in lateral position. We have to mark the spinous processes of the lumbar vertebra. One thing to be noted here, it is not midline, it is the spinous processes, because midline may vary in patients having kyphoscoliosis. So what we mark here is the spinous processes. Next is the Taffier's line, that is the intercristal line. It may or may not lie at the level of alpha vertebra. Next is the posterior superior iliac spine, which can be identified as a skin dimple over the skin on the buttocks. So So what? Now that we have seen the surface landmarks, let's have a look at the lumbar plexus block. So this is the midline, that is the line 1. Next line is the Toffia's line or intercostal line. Next is we have to draw another line that is crossing the line 3, that is the Toffia's line at the level of PSIS, which is parallel to the midline. Now, there are various approaches to the block. We have one point is we can insert the needle at the intersection of line 2 and line 3. However, this point will be not corresponding to the plexus exactly. It will be very much lateral. Next is we have to divide the line which is joining the line 2 and line 1 into 3 parts. And the needle insertion will be at the junction of the lateral 1/3 and medial 2/3. This quite corresponds to the lumbar plexus. One more approach is what Shiv sir has described. It will be the approach for the lumbosacral block combined. We have to draw a line joining the spinous process of L4 to the PSIS and divide this line into thirds. And we have to give the drug at the junction of the lateral 1/3 and the medial 2/3, which corresponds to the plexus. And if we give proper volume at this level, we can block both the lumbar as well as sacral plexus. So what is safe approach to the lumbar plexus? So we can see here, this is the skin and subcutaneous tissue. This is the vertebra and the spinous process. This is the transverse process. So once we pierce the skin and subcutaneous tissue, the distance from the skin to the transverse process, this may be variable distance. It can vary according to BMI, obesity, gender, etc. It varies, like it's around 4 to 6 centimeter. But however, the distance of the plexus from the transverse process is relatively fixed distance, not more than 2 centimeter. So once you hit the transverse process, you never go beyond 2 centimeter in order to spare the vital structures. Here we can see the crest, iliac crest not always corresponds to the L4 level. Once we hit the transverse process, we may walk off or walk over it. It's always preferable to walk underneath to block all the multitude of the nerves together. This slide shows the drug spread according to the approach by Shiv sir, that is the lumbosacral plexus block. You can see here it nicely covers the area of the lumbar plexus as well as the sacral plexus. So these are the different approaches for the lumbar plexus block. What we have described, that is at the junction of the lateral 1/3 and medial 2/3, is the Capdeville approach. Now the catch here is we have to look for the transverse process and hit the transverse process and then go further. So hitting the transverse process is important because it indicates that you are at a particular depth and the needle depth can be gauged, which prevents very deep approach. However, in Vinny's approach, it is at the intersection of the PSIs and the intercostal line, the entry point being lateral. So the contact process is not contacted. So the transverse process is not always contacted. So the depth cannot be gauged, and you can always enter too deep. The chains and decrease are another approaches, but however, there is always decrease approach is a higher approach at the L3 level. So there's always a risk of renal injury. And the chains approach at the L5 level, it's too medial. So there's always a risk of epidural drug spread. Here we can see the comparison of the needle insertion point for the Capdeville and Vinny's approach. The red here is the Capdeville approach, which we usually do, whereas the Vinny's approach, it is a little bit too lateral. So what is the ideal response? That is the quadriceps stretches.
Now we reduce the current here.
So once we have inserted the needle, you might not get quadriceps twitches every time. What other structures can we encounter? So once we have entered the skin, we will encounter the paraspinal muscles. So the paraspinal muscles, upon stimulation, it will give local twitches. It is usually the initial response. Now we have to, it means needle is superficial and we have to go further inside. So after that, we contact the transverse process, which is actually what we are looking for according to the Capdeville approach. The transverse process is contacted, and we can gauge the needle depth. Later, we can, upon going further inside, we encounter the psoas muscle. Okay, so the lumbar plexus is basically lying within the substance of the psoas muscle. So initially, we get the lumbar plexus response, that is the quadriceps twitches. However, if you are going too inside the psoas muscle, you may stimulate the muscle directly and get thigh flexion, which is not what we are looking for. If we go further deep inside, we may hit the vital structures and hit the kidney or go intraperitoneal. Here we can see what we have talked already. Paraspinal muscle stimulation will give local muscle twitches, and psoas muscle direct stimulation will cause thigh flexion. If we encounter the sciatic plexus, obviously it is lying caudally, so we are going directed cranially. Too deep. It means we are at the wrong insertion site and we need to assess our landmarks again. So the depth of the lumbar plexus, this we have already discussed. The distance from the skin to the transverse process, it is a variable distance, approximately 6 to 8 centimeter. However, the distance of the lumbar plexus, here it is lying inside the psoas major muscle. The lumbar plexus from the transverse process, it's a fixed distance. It is only 18 to 20 mm. So once we hit the transverse process, never go beyond 2 centimeter. Otherwise, you will end up going further forward and hitting the vital structures. This we already discussed. Also, avoid going too near to the middle, because the dural sleeve may extend up to 3 centimeter at the lumbar level, and if you are too near to the midline, you will definitely get a strong response, but you may end up giving the drug intradurally or inside the epidural space or even intrathecally. So never go beyond 3 centimeter from the midline. So what are the complications of the block? Hypotension, first and foremost. The hypotension will obviously occur because it will block the sympathetic system, but unlike neuraxial block, it is only unilateral, so it is usually easily manageable. Next is the direct neural injury. So avoid giving the drug beyond 0.4 milliampere current. If you go beyond too much, you may directly give the drug intraneurally and cause damage to the nerves. Next is the local anesthesia systemic toxicity. Okay, so it can occur in many ways. First and foremost, the lumbar area is very vascular area. It has lumbar arteries lying all along. So always aspirate before you inject. To avoid giving the drug intravascularly. Next is you can keep the needle open to the air. So if it is open to the air, if you are going intravascular, then the blood will come back and you can avoid giving the drug over there. Next thing also to be considered is usually we give these blocks for anesthesia purpose in ortho surgeries, and these patients are usually very thin and fragile and frail patients. So you have to always reconsider the drug and volume to be given. If you give any volume which we usually give in normal adult patients, you will end up with giving overdose and end up with last. Next is neuraxial anesthesia. We have already discussed, avoid going near to the midline. Also, keeping the needle open to the air, it will also detect any CSF backflow, hence avoiding the drug given under the spinal space. Next is damage to the abdominal viscera. Avoid going too deep. Don't go 2 centimeter beyond the transverse process to avoid the damage to the vital structures. And retroperitoneal hematoma. Here we can see the dural sleeve extending right up to the origin of the spinal. So what are the take-home messages? Know your block, know the related anatomy, mark the landmarks accurately. The landmarks, if they are not accurate, you will end up going elsewhere. Also always imagine the path of your needle, where it is going and where it should not go. Never go very near to the midline to avoid epidural or spinal injection. Once you hit the transverse process, never go beyond 2 centimeter. Avoid fast and forceful injections and keep the needle open to air while locating the plexus. That's all. Thank you. Any questions?
Excellent, Alka. I think there was no questions. I think you cover all the aspects of the lumbar plexus block. If any question comes in, then I will likely pose it to you, or we'll answer those questions. We can continue with the sacral plexus block.
Sure, let's go ahead with the sacral plexus. Is it visible, sir?
Go on.
Okay, so let's discuss the anatomy for the sacral plexus block. So we'll have a look at the formation and location of the sacral plexus, the branches that come out. Use the term parasacral for the block. What are the surface landmarks? How to approach the plexus? What ideal response do we get on the PNS? What if we don't get the ideal response? How to troubleshoot, and some tips. So the sacral plexus formation, as we already discussed, there will be a ventral rami and the dorsal rami. The ventral rami will take part in forming the sacral plexus. So the ventral rami of the L4 and L5 vertebra, they will form the lumbosacral trunk, which will descend down into the pelvis and combine with the ventral rami of the spinal nerves at the sacral level, and they will combine to form the sacral plexus. Here we can see the L4, L5 forming the lumbosacral trunk, combining with the sacral nerves, and this is the final sacral plexus giving off its branches. So let's have a look at the branches in detail. So the rami will again divide into divisions, that is the dorsal and ventral divisions. So the main nerves of the plexus, that is the sciatic nerve and the posterior femoral cutaneous nerve, they are branches formed from the dorsal as well as ventral division. The sciatic nerve will give off two components, that is the common peroneal and tibial component. The branches solely from the ventral division will be the nerve to the quadratus femoris, obturator internus, and the pudendal nerve. And the branches from only the dorsal divisions will be the gluteal nerves, nerve to piriformis, and perforating cutaneous nerves. So what is the location of the sacral plexus? It's obviously located in the pelvis, on the surface of the posterior pelvic wall, anterior to the piriformis muscle. Here we can see the posterior view. This is the piriformis muscle. This is a view from the back side. So the piriformis muscle has been made transparent. We can see the sacral plexus line anterior to it. It is caudal to the lumbar plexus. And one more thing to be noted is the gluteal vessels will follow the same course as the sacral nerves in the anterior plane. These gluteal vessels, they serve as a landmark, important landmark when we scan the nerve plexus using ultrasound guidance. What is the sacral plexus distribution? It will supply mostly the posterior structures. Here we can see the distribution. It will innervate the skin of the medial part of the thigh and gluteal area. Also innervates the hip joint. So let's have a look at the branches in detail. First and foremost, the sciatic nerve. It is the thickest nerve in the body and essentially a continuation of the whole of the sacral plexus. It will arise from the L4, L5, S1, 2, and 3. The sciatic nerve has two components, the tibial and common peroneal component. They both are embedded within the peroneural sheath. However, one thing to be noted is they are distinctly separate. They are just embedded from the origin to the termination. The tibial nerve component will lie anteromedially and the common peroneal will lie posterolaterally. So what is the course of the sciatic nerve? In the pelvis, the roots will combine to form the main trunk of the sciatic nerve anterior to the piriformis muscle, and then it will enter the thigh via the foramen, sciatic foramen. Next, in the infragluteally, there is a small area where the nerve, sciatic nerve, is covered only by skin and subcutaneous tissue, sparing any muscles. So here it lies more superficial along its whole course. Then in the distal thigh, it is crossed by the biceps femoris, and in the popliteal fossa, it finally divides into two branches, that is the tibial and common peroneal nerve. Here we can see this is the piriformis muscle. The nerve is lying anterior to it, and these are the inferior gluteal vessels which are lying in relation to the sciatic nerve. Next is the posterior cutaneous nerve of thigh. It arises from S1, 2, and 3. This thin twig here, which is running along the sciatic nerve, it is the posterior cutaneous nerve of thigh. It supplies the skin of the posterior, as the name suggests, it supplies the posterior area of the thigh, buttocks, and variable area of scrotum and posterior calf. One thing to be noted is it is physically separated from the sciatic nerve by the hamstring muscles after it crosses the GTIT line. What is GTIT line? That is a line joining the tip of the greater trochanter and the ischial tuberosity. If you draw an imaginary line, any block which we give proximal to this, it will essentially block the posterior cutaneous nerve of thigh in the single injection. However, any block which we give caudal to this line, that is the GTIT line, it will spare the posterior cutaneous nerve of thigh because it is essentially separated from the sciatic nerve by the hamstring muscles. So this thing has to be kept in mind while blocking the nerve. Next are the gluteal nerves. Superior gluteal nerve arises from the L4, 5 and S1. Here it is the superior gluteal nerve. It lies superolaterally to the sciatic nerve. This is the sciatic nerve. It supplies the gluteus minimus, medius and TFL muscle. So while approaching the sciatic nerve, if we stimulate the supragluteal nerve instead, we will get a TFL contraction, which clinically we can see a twitch on the most lateral aspect of the hip region, indicating that our middle tip is superolateral and we need to redirect it towards the sciatic nerve. Next is the infragluteal nerve. It arises from L5, S1 and S2. Here we can see it lies medial to the sciatic nerve and supplies the gluteus maximus muscle, which covers the whole of the buttock. So while approaching the sciatic nerve, if we get a twitch, if we stimulate the infragluteal nerve, if we stimulate the inferior gluteal nerve instead, we'll get a contraction in buttocks, which indicates that our needle is still distal to the parasacral point and we need to redirect it more laterally. Next is the pudendal nerve. This nerve arises from S2, 3 and 4. It supplies the pelvic region, including the genitals and the inner perineal area. Pudendal nerve, it is never desirable to block this nerve. However, it is always blocked when we give the sacral plexus block, causing numbness in the perineum or penile shaft. It is only temporary and harmless, but it is very distressing for the patients. So always keep in mind to explain the patient beforehand, before giving the block, that you'll feel some numbness in the perineal and shaft area and it will go away. Next are the muscular branches. It supplies all the muscles associated with the posterior capsule of the hip joint. These muscles are external rotators. As we can see here, it is the piriformis, the gamelli muscles, that is the superior and inferior gamelli, the obturator internus, and nerve 2 quadratus femoris. Next is nerve 2 hamstrings. Okay, this is also important. The nerve 2 hamstrings is already formed in the parasacral area. We can see here this thick structure here is the sciatic nerve, and this thin blue line, it is the nerve 2 hamstrings. Okay, so it is already formed in the parasacral region. However, it accompanies the sciatic nerve very closely until it crosses the ischial tuberosity. After it crosses the tuberosity, it is separated and it is embedded in the hamstring muscles. Here we can see the semimembranosus, semitendinosus, and biceps femoris, which combine to form the hamstring muscles. So they will embed the nerve 2 hamstrings within themselves, physically separating it from the sciatic nerve. So why is it important? So while giving the sciatic nerve block, if we give any block cranial to the GTIT line that we already discussed, the line joining the greater trochanter and ischial tuberosity, if we give any block cranial to this line, hamstring twitch will be a perfect endpoint because the nerve 2 hamstring has not yet been separated from the sciatic nerve. However, if we give any block caudal to this line, the nerve 2 hamstring is already separated from the sciatic nerve, hence we cannot rely on hamstring twitch as an endpoint. The block will fail. So now it's sometimes very confusing whether it is sciatic nerve block or sacral plexus block. Is it the same? Is it different? So Mansoor's technique, Mansoor originally described a parasacral block at any point lateral to the sacrum and caudal to the sacroiliac joint. Here we can see. However, sacral plexus, it is called sacral plexus block, not sciatic nerve block, because it will giving drug over here at this injection point, it will block multitude of nerves and all of the nerves will get blocked along with. So we can say truly that parasacral approach to the sciatic nerve is true sacral plexus block. Our main target is always stimulating the sciatic nerve. Hence, it is known as parasacral approach to the sciatic nerve. It is one of the most proximal approach, and it will block almost all of the nerve, that is the tibial and common peroneal components, along with the posterior cutaneous nerve of thigh. All these three branches emerge together above the piriformis muscle, where exactly they are giving the block. So now we have discussed the branches in detail. Let's discuss what are the surface landmarks for the block. So the patient will be lying in the lateral position with the limb to be blocked on the upper side. So we have to mainly mark only two landmarks, that is the PSIS, posterior superior iliac spine, and the ischial tuberosity. The PSIS we can mark as the dimple on the skin of the buttocks. Sorry. And ischial tuberosity, it usually is the lowermost bony prominence. It is usually the bone upon which we sit. So we have to draw a line combining PSIS and ischial tuberosity, and needle insertion point will be 6 centimeter over this. That is the Mansour's approach. Okay, let's see what I'm talking about here. Mansour's approach is the needle insertion point will be 6 centimeter over this line. However, what is the problem here? It is a fixed landmark. Okay, 6 centimeter is a fixed landmark. In tall patients, it may not always correspond to the sacral plexus lying underneath. It may be still caudal. So we have modified Mansour's approach, which divides this line into 3 parts, and a needle insertion point will be at the junction of the cranial 1/3 and caudal 2/3, which is more reliable and corresponds to the plexus lying underneath. Okay, why this line? The PSIS and IT line, here we can see the PSIS and IT line, it corresponds to the sacrotuberous ligament, which is in relation with the sciatic nerve. Here we can see the comparison of the needle insertion point in different approaches. Okay, so parasacral approach, many literature have described parasacral approach as any needle insertion or any approach to the sciatic nerve in the buttocks, but that is not true. Labat, Sweeney, subgluteal, Raj block, all of these are approach to the sciatic nerve and not the sacral plexus as a whole. So what is the ideal response? Here we can see. Okay, so at the level of, So at the level of parasacral approach, any response is acceptable. That is plantar flexion of the foot or toes, the dorsiflexion, or any palpable twitches of hamstring. All of them are acceptable. Here we can see at the junction of 1/3 and 2/3. This is the initial gluteal response which he was getting. This is the end response, that is the dorsiflexion. Okay. So we might not always end up with ideal response. What are the structures we may encounter and what other responses we may get? So after entering the skin and subcutaneous tissue, we may encounter the gluteal muscles, which we already discussed. It will give local twitches and we need to redirect. Okay, so local twitches means that our needle is superficial and we need to go further deep inside. Next is we can also encounter obturator nerve, which is rare, but if at all you encounter obturator nerve, here we can see it lies much anterior. That means our needle is too deep and we need to withdraw it. Bony contact may happen if we hit over the boundary of the sciatic fossa. Next, what are the complications? First and foremost is last, as we already discussed. These patients usually we give sacral plexus block in combination with lumbar plexus block for lower limb surgeries. These patients are old and frail, so we need to always reconsider total dose and volume of the drug and avoid giving intravascular. Always keep the needle open to the air. Next is hypotension. It is usually easily manageable. Direct nerve injury, avoid giving the drug beyond 0.4 milliampere. Urinary disturbances will happen. So this is to be kept in mind. If you are giving bilateral sacral plexus block, always catheterize the patient beforehand. Numb penis and perineum due to block of the pudendal nerve, we have already discussed it. Always explain the patient before giving the block that you will that this will be temporary and harmless. Next is bowel injury. It may happen if you are going too deep, and pudendal nerve injury may happen. So the slide is important. Clinically, what if a patient comes to you? What block will you give? So for the anesthesia of entire lower limb, here we can see these are the dermatome, myotomes, and osteotomes. They are already visible. This is the anterior and the posterior view. So for anesthesia of entire lower limb, we obviously need both the lumbar and sacral plexus. For anesthesia of lower limb below the knee, only below the knee, you have to block this area over here. It is supplied by the sciatic nerve, the orange area, and the purple strip is supplied by the saphenous nerve, which is a branch of femoral nerve and thus the lumbar plexus. So if you want to anesthetize below the knee, you have to give sciatic nerve block along with approach to saphenous nerve block, that is adductor canal or femoral nerve block. Take home message: you know your block, know the surgery, know the related anatomy, and select the right block according to the surgery. Mark your landmarks accurately. Modified Monsoons is preferable over the Monsoons technique because it has a variable landmark. And at parasacral level, any response is acceptable. That is visible or twitches of hamstring or foot, dorsiflexion or plantar flexion, toes or calf muscle. That's all. Thank you. If you want to know all of these blocks in detail, please join us at NBFM Surat, which is to be held on 2nd and 3rd December. You can scan this QR code directly and register for the same. That's all. Thank you.
Thank you, Alka. I think you covered both topics really, really well.
Thank you, sir.
You can switch on your video camera now if you're not presenting. I think it did make a difference switching off your thing because there was still slight lag at times, but I think it helped not to have your video because it takes away a lot of your data on the network. Excellent presentation, both topics so very well covered. And everybody knows that these are two plexus blocks, which are one of my favorites. I call them mother of all blocks, especially the lumbar plexus block. And not very many people actually venture into this area, especially in the UK. People are damn scared of actually giving them. And the reason being that they have had total spinals with them, and cardiac arrests have been reported. So they are very scared of these blocks. And that brings to the question Dr. Menon asked, and I actually, I've answered it in the chat box. Why do we actually leave the extension tubing? We do not need to prime, and we do not need to connect anything till you get the right response and stop. That's only when you actually inject. A few ml of air in that area does not affect your block. It's not like epidural block where injection can actually cause a little bit of patchy block. It's not like that. But I've been giving these blocks. I've given more than 1,000 of this. And I've had 5 cases where my trainees and some of my consultant colleagues whom I taught actually came back and said, thank you for teaching us this technique. We saw CSF coming, and all we did was again check the landmark, come out, check the landmark, and go, and they were able to do them successfully. So yes, do not connect. So I would say that do not connect anything, and do not prime it. So if you give local into it and it seeps back for whatever reason, you will think it's CSF. It's not necessarily that. So don't prime the tubing, and do not connect anything to that. I've had 1 or twice, you will likely see some small blood coming out. Again, you can either flush it and see if it stops, fine. If it doesn't stop, then take out and go to another level or another landmark. So landmarks are very, very important. You need to draw them when you're starting off. I don't do it because of my experience. Now I can actually go without drawing them and going. But if you're starting off, always draw the landmarks. Learn to do the technique. Capdevilar technique is the most safest one, as you've all rightly explained. And now, unfortunately, we were actually going to go to the ankle straight away with Anil. We missed out in between. We missed out the anatomy of the femoral, sciatic, and obturator. So I'm going to actually go through them briefly, just to complete the whole lecture. Okay. So these are some things we actually missed out. And I'm just going to go through them in a little bit of this thing. So these nerves we missed out between the your lumbar and sacral plexus, which Alka has. So a little bit of repeat will be there, but I think we will. So we'll be talking about the your femoral nerve, little cutaneous, obturator nerve, and sciatic nerve between the pelvis and the foot. Formation, already Alka has talked about it. The femoral nerve and the obturator nerve have the same origin. One comes from dorsal division, other from the ventral division. The little cutaneous nerve. And present I will be talking about the ilioinguinal iliogastric nerve, so we're not going to actually talk about them at all. Sacral plexus, again, I think main nerve is going to be just sciatic nerve. That's what we're going to talk about. Superior gluteal nerve and inferior gluteal nerve, they become important when you want to know if you get these responses. Alka mentioned how you need to actually go either superiorly or inferiorly or lateral to the response to get the proper sciatic response. Okay. So if you look at those nerves from the lumbar plexus, so the lateral cutaneous nerve comes out from the lateral aspect of the psoas pretty early on. And then as you go down, the femoral nerve comes on the lateral side. Genitofemoral nerve also comes out early on, but it lies anterior to the psoas muscle. And the obturator nerve lies on the medial side of the nerve. So if you look at these nerves in the schematic diagram, on the medial side is your obturator and the accessory obturator nerve. On the lateral side, on the middle of the or anteriorly is the genitofemoral nerve, and on the medial side is the femoral and the lateral cutaneous. Lateral cutaneous more proximally and femoral distally. And we know that the femoral nerve lies below the inguinal ligament, and it tends to divide into two of the branches very quickly. Okay, so it is not very far from the inguinal ligament. So if you are trying to block the nerves more distally, you may not get the right response. So you need to be as close to the your inguinal ligament as possible. And the little cutaneous nerve tend to arise over the your fascia iliaca, whereas the your femoral nerve lies below the fascia iliaca. So that's the difference between the two, and that becomes important when you're doing fascia iliaca block. So if you look at the L5 level, you will see that the femoral obturator nerves are lying just medial to the the psoas muscle, and then later on the femoral nerve will move laterally. But you look at the genitofemoral nerve, it is lying on the lateral side, whereas the lateral cutaneous nerve has already moved out and it's lying on the very lateral side. It's not shown in this image, but it's already given away at that level. So when you're doing the lumbosacral block, which I was talking about, mentioned that it gives, if you give large volume, you need to actually have it distributed more proximally, then you will catch the lateral cutaneous as well. Otherwise, if you use smaller volume, you will miss out on the lateral cutaneous nerve. Sciatic nerve, already mentioned, we will be talking more about below the, the greater trochanter and ischial tuberosity line, and in the popliteal fossa, so where the Raj approach is. So at that level, it lies above the chordatus femoris and is still covered by the gluteus maximus when you do the Raj approach. And all these are like, they have all articular branches, motor branches, cutaneous branches. You got articular branches to the hip joint. You got to the knee. The motors are mainly to the cordyceps. That's what you see as a response. That is the when you get the patellar dance, when you stimulate the femoral nerve. And cutaneous, it supplies, the anterior cutaneous and the medial cutaneous come from the femoral, as well as the below the knee. On the medial side is your saphenous. And the articular branches from the your tibial nerve goes to the knee joint and also to the ankle joint. And similarly, the muscles, they supply if you look at tibial, it supplies more of the flexor compartment of the leg. And it supplies the foot as well, because it goes to the sole of the foot. So all the muscles on the sole of the foot are supplied by the tibial nerve via the lateral and the medial plantar nerves. The skin over the most of the if you look at the tibial nerve, it supplies most of the leg part of the nerve. It also gives off the sural branch, so it's got a sural communicating branch. So tibial and peroneal, both of them, supply the sural nerve as well. This is a common peroneal nerve. Then again, genicular branches to the knee as well to the ankle joint. Motor to the lateral compartment of this. So the peroneals, longus, brevis, tibialis anterior, those muscles are supplied by the common peroneal nerve. And the ankle joint, of course, gets them as well. The cutaneous is most of the leg. Common peroneal nerve supplies most of the leg through the superficial and deep. The plantar aspect is supplied by the peroneal nerve. So knowing your osteotome, dermatomes, and myotomes are very, very important. And if you look at the skin, and everything below the knee is supplied by the branches of the sciatic nerve, except from the medial side, which is the saphenous. And on the back of the leg as well, most of it is supplied by the branches of the sciatic nerve. Whereas the thigh is mostly by the lateral cutaneous and the your femoral nerve, except for the posterior part, posterior cutaneous nerve of the thigh, which is actually coming from sacral plexus. It says sciatic plexus, but it should be ideally be the sacral plexus. Coming from the sacral plexus, supply the posterior part of. And myotome, again, the cords are by the femoral, rest of the legs. The adductors are, the abductors are from not the abductor. Adductors are from the obturator nerve. And below the knee, most of it is by the peroneal, common peroneal and tibial nerves. So again, similarly, again, below the knee, most of it by the your sciatic nerve. The femur is supplied by all three. Near to the head, it's important that the joints are supplied by all three nerves, the femoral, obturator, and sciatic. Posterior part of the femur is supplied by the your sciatic nerve as well. So almost like 2/3 of the femur is supplied by the femoral, and 1/3 each by the obturator and the sciatic. Probably sciatic goes slightly more component than the obturator nerve. So obturator nerve, this is important when we're doing the urological surgeries. So your something called obturator kick comes in. And like I said, it does supply the hip joint as well as the knee joint. So it has got a smaller component to knee joint, larger component to the hip joint. It is one of the main pain generators for the hip joint is obturator nerve. That's where lies the importance of the obturator nerve. It supplies all the adductors, the adductor brevis, longus, and other muscles as well in the thigh. So it's on the medial side. And cutaneous supplies onto the medial side of the thigh. Motor I've already described. So it divides in two branches. It divides into your cutaneous branch and, your anterior branch and the posterior branch. And then also the dorsal branch. So when you're actually doing block, next to the pubic tubercle on the medial side, you will, ultrasound, we see that, but the local anesthetic tend to spread proximally and block both the nerves. So that's important. So for the femoral nerve, we all know it lies lateral to the artery. So you got the vein, artery, and nerve. You go just lateral to it. I tend to go more closer to the what is in this. But when you are going little more distal, you tend to angle the needle towards the ligament. And try to get the good response. You need to actually look at the patellar dance. Don't look, if you are getting the sartorius, which I'll explain in a minute, in that case, you need to actually just reposition your needle. For the obturator nerve, you look at the pubic tubercle, you mark it, and you go 2 centimeters down, and then go laterally to that point. Either way, whether you go 2 centimeters medial and down, or down 2 centimeters, lateral, is the same thing. So you get that point, and you will get the contraction of the adductors. So for the femoral nerve, we always look for the dancing of the patella because of the cords which are attached to the patella. The patella will contract and it's called patellar dance. And if you are actually getting a sartorius twitch, that is a medial twitch, then you are too superficial, you're too anterior. You need to go a little bit lateral and deeper to the posterior division to get the your patellar dance response. This is looking at the obturator nerve. So from the pubic-tubercle, 2 centimeters down and 2 centimeters laterally, and angulate the your needle slightly cranially so that the local anesthetic spreads more proximally to so that the obturator nerve is blocked before it divides into 2 components. And motor response for that is again from your adductors. You will see a very strong twitch from that. Now, lateral cutaneous nerve becomes important because it supplies the lateral side of the thigh, and you can block it easily. You just need to go, 2 centimeters, 1 to 2 centimeters, sort of medial to the anterocephalous spine, and 1 to 2 centimeters below it. Go through the skin, feel for a bounce on the fascia lata, a single pop, and deposit around 7 to 10 mL of local anesthetic, and you block the lateral cutaneous nerve. There is no motor response to it because it's only a purely sensory nerve. Saphenous nerve can be blocked at various levels. Okay, so there are various, so there can be perifemoral, so if you're blocking the femoral nerve, you're going to block the saphenous nerve. You can block it below the subsartorius, that's sartorius muscle, lower down. You can block it near to the knee, that's a transsartorial approach. Now you can use a nerve stimulator and subsartorial or transsartorial approach because the nerve to vastus medialis lies very close to it, and you will see twitching of the vastus. So you get a response from the vastus. Saphenous nerve is purely sensory, but you can actually get a response as well, motor response. Most common place to block is near to the medial femoral condyle. Just below, actually, it's a tibial condyle or perivenous kind of approach. You just infiltrate below the skin, but that's the wrong thing. You need to go, if you're near to the knee, near the tibia, proximal end of tibia, you should actually feel a click through the fascia, investing fascia there. Whereas it comes out through the deep fascia and then goes along the greater saphenous vein. So if you're near to the knee, feel for a click through fascia and deposit local anesthetic, and it lies more posteriorly than anteriorly. So if you are going from the tibia anteriorly, you need to go slightly more posterior. So go more posteriorly than anteriorly. You can block it near the ankle as well as part of the ankle block, which Anil will actually cover. So coming to fascia iliaca block and lateral cutaneous block, like explained, if you're near to the anterocephalous spine, 1 to 2 centimeters, sort of medial and caudate, feel for a single click through the fascia lata. For the fascia iliaca, you need to divide the inguinal ligament into 3 parts, and the junction of the lateral 1/3 and medial 2/3, you need to feel 2 pops. So you're away from the vessels, you're away from the nerve, so you can't cause nerve injury, you can't cause any hematoma, you can't be causing intravascular injection. Pretty good block. And you give large volume, it'll spread along your psoas muscle and block the femoral lateral cutaneous. And if you give large enough volume in a smaller patient, it might spread proximally. So this is also known as the perivascular approach to the the lumbar or psoas compartment block. Now, sciatic nerve below the, where the sacral plexus are given, which Alka mentioned, you can go between the greater trochanter ischial tuberosity, or you can block it more distally in the posterior sciatic. So that is a classical approach to the sciatic nerve, where you mark the greater trochanter and the posterior spherical spine. And I'll show it in a diagram, I think better that way. So that is the sacral hiatus, posterior spine, greater trochanter. You draw a line from these two, from greater to PSI, then a line from the greater trochanter to sacral hiatus, then take the junction of the first line and drop it onto the second line. And that's the point where you will actually do the classical sciatic nerve block, proximal sciatic nerve block. The other block is the Raj approach, where somebody lifts the leg, you feel for the greater trochanter. The advantage is that when you're sort of flexing the hip, the nerves become very, very superficial because stretching the tissues, and you go in midpoint between the greater trochanter and ischial tuberosity, and you get the same response as you would get for any sciatic nerve. So you can see the dorsiflexion or plantarflexion of the foot. So somebody need to hold the leg in that position. So that's a position of the leg. Great. I think I used to love this approach before I was using ultrasound for proximal sciatic nerve blocks. Popliteal fossa, everybody knows there are two methods. So you can mark the center of the popliteal crease, midpoint, take it up around 7 to 11 centimeters, and go slightly lateral. That mark is actually lateral. You need to go. The sciatic nerve at this point lies slightly lateral, not medial, not at a point. So that is one of the classical approaches to popliteal sciatic. You need to be slightly 1 or 2 centimeters lateral to the that point I've marked, And then there is something called the intertendinous approach, where you feel for the face. You can feel it yourself. I mean, try feeling your popliteal fossa. You will feel the bicep femoris tendon on the lateral side, and you will see the semitendinosus on the medial side. You will see two tendons. You mark those two tendons up, and you go between those two tendons exactly at the midpoint, 7 to 11 centimeters, and that will give you absolutely amazing block. I mean, you will get the response very, very easily. You might actually have to fiddle around. So when you're not getting a response, come out and go slightly lateral. Usually the nerve lies more lateral than medial. So remember that point. You can also give blocks, and patient on the lateral approach. So, you need to go from the femoral condyle. You need to actually go between your vastus lateralis and the bicep femoris, that groove. You go around 11 centimeters. You hit the femur and then redirect your needle around 30 degrees till you get the sciatic response. So that is the lateral approach to that. One of the things important is that you ask somebody to hold the leg and turn the foot inwards. That is the advantage. That brings the nerve again more closer to your lateral point. So that is important. So you don't let the leg drop lateral. That's a natural thing. Ask somebody to actually hold it and turn inward. So the foot, that helps in doing the lateral approach to the thing. You can also block it proximally, and so from the greater trochanter, you come 2 centimeters, and then from there you go down 4 centimeters, and that point you can block it much more sort of proximally compared to one for the popliteal fossa. I think this one was covered already. Motor responses, if you're doing a tibial. Now, if you're blocking it proximally, then we are okay with either of the response. But if you're in the popliteal fossa, you want to actually see the tibial response, which is the plantar flexion of the foot and toe and inversion of the foot. If you're getting the dorsiflexion of the foot or abduction of the foot or reversion of the foot, that is the deep peroneal or superficial peroneal response. Try to avoid this response if you're in the popliteal sciatic area. So always look for the plantar response, tibial response when you're doing the popliteal sciatic blocks. So femoral nerve, using PNS, look for patellar dance, Neville Sartori response. Fascial iliaca block, again, larger volume. Lateral cutaneous block, easy to do. Sciatic block, you can do it proximally or in the subgluteal area. The Raj approach is excellent area, or you can do distally at the popliteal crease. These are wonderful blocks to do if you know them. Saphenous, I've not mentioned that again. Saphenous, you can ask the surgeon to infiltrate at the incision point if it is small, even if you don't do the block. But any surgery below the knee, you can do with the popliteal sciatic. But if we are doing surgery near the proximal tibia, like tibial plateau fracture, I would suggest that you combine the popliteal with femoral. That gives you a better analgesia than the doing the popliteal sciatic and saphenous block. Okay, thank you, and I would actually take any questions if there are any questions on this, and if not, we will actually go to Anil in a minute. So there is a question. Good spine anatomy makes very clear. What's the chances of hypertension or intrathecal injection? Okay, so chances of hypertension are with, if you look at lumbar plexus block, you do get some amount of sympathetic block because your sympathetic chain is lying anteriorly. The local anesthetic can spread to it. But intrathecal injection will happen if you don't follow our rule. If you don't know that, and if you're medial, very common to actually go a little medial, because when you're looking for the skin, you tend to stretch it and you release it, the point comes in, and you will actually go medial. So always be careful with doing intrathecal injection. It has been reported quite commonly in the literature with lumbar plexus block. So be careful with your landmarks. So don't stretch the skin too much. If you're seeing the nerve, then you are actually too medial. Like I say, if you can measure it. You can measure the distance between the spine and your point. If it is less than 3 centimeters, rather even 4 centimeters, then your landmark is wrong. You need to actually go a little bit more than that. Since there are no other questions, I think femoral, sciatic, and these are people are very clear with the landmarks and things like that. I think we will move on to ankle with Anil. Is it okay, Anil? Yeah.
Yes, sir. Am I audible and visible, sir?
Yes. You can start doing the, yeah, there you go. Yeah, slide.
Good afternoon, everyone. I'm back with one more lecture, ankle block and its applied anatomy. So this is the overview of my topic. It's a very short lecture. I'll straight away go ahead with the lecture. So what are the advantages of ankle block? So it is done for any surgeries from foot, involving the foot and ankle below the malleoli. There is no foot drop, so it preserves ambulation. Relatively quick to perform. It is suitable for bilateral surgeries, and it's suitable for daycare surgeries as well. The only limitation being we cannot apply a tourniquet, and that will be difficult to do. So there are 5 nerves involving the ankle block. The first 4, tibial, superficial peroneal, deep peroneal, and the sural, are the branches from the sciatic nerve, whereas the saphenous nerve is a branch from the femoral nerve. Let us have a look one after the other. So starting with the tibial nerve, sir has already covered in his previous lecture. I will only tell you about the tibial nerve and its branches at the foot level. So tibial nerve has 3 branches at the level of foot. One is the medial plantar nerve, lateral plantar nerve, and the calcaneal branch. The medial plantar and the lateral plantar nerve supplies majority of the intrinsic muscles of the foot, except for the extensor digiti brevis, which is supplied by the deep peroneal nerve. The other branch, both this branch, medial and the lateral plantar nerve, also has a cutaneous nerve supply. Coming to the peroneal nerve and its branches, the common peroneal nerve, after its bifurcation from the sciatic nerve at the level of popliteal fossa, runs inferiorly, winds at the level of the fibular head, and gives off a sural communicating branch, and divides into superficial peroneal and the deep peroneal branch. The superficial peroneal nerve is responsible for muscular supply over the lateral compartment of the leg, whereas the deep peroneal nerve has a motor supply supplying the anterior compartment of the leg. The deep peroneal nerve, as I said, has a motor supply to the extensor digitorum brevis, which will help in extension of the thumb. The superficial peroneal nerve runs on the lateral aspect and it gives off nerve supply to the peroneus longus and brevis. And this component of the superficial peroneal nerve is utilized for giving a motor nerve stimulation, which we'll come to later. So to summarize the dermatomes, here we can see that the majority of the dorsum of the foot is supplied by the superficial peroneal nerve, and only a small part of the inside of the cleft between the first and the second toe is supplied by the deep peroneal nerve. Medial side over the malleoli is supplied by the saphenous nerve, and the lateral small thin strip is supplied by the sural nerve. In the dorsum of the foot, it is mainly by the posterior tibial nerve through its 3 branches. The medial calcaneal branches supplies the heel of the foot. The medial plantar and the lateral plantar supplies majority of the rest of the foot. Sural nerve has a small thin supply over the lateral aspect of the plantar side of the foot. The most important nerve in the ankle block is the posterior tibial nerve, because it's the biggest of all the nerves. So the posterior tibial nerve lies behind the medial malleolus and close relationship to the posterior tibial artery, and it lies behind the flexor retinaculum. This is an important landmark to know while giving the posterior tibial nerve block. And also in the cross section, you can see it lies in front of the tendo Achilles and behind the medial malleolus. After its division into medial and lateral plantar nerve, as I discussed previously, it supplies majority of the intrinsic muscles of the foot except for the extensor digitorum brevis. So what are the landmarks for the ankle block? This is a summary to excuse me. This is a summary to cover the landmark guided ankle block. The superficial peroneal nerve, as I said, I'll get the pointer here. Okay. The superficial peroneal nerve lies in front of the, comes through the lateral compartment, and in front of the ankle, it divides into multiple branches which has a majority of supply as discussed previously, and it supplies dorsum of the foot. So to block the superficial peroneal nerve, we start with an infiltration from the medial malleolus up to the lateral malleolus. This is recommended because it will cover most of the superficial peroneal nerve and its branches. Because the variation of the superficial peroneal nerve is quite extensive. Next is the saphenous nerve. The saphenous nerve can be blocked just above the medial malleolus with a subcutaneous infiltration. I have a pictorial representation that will be easier to explain. I'll come in detail on how to give a saphenous nerve block in the coming slide. The posterior tibial nerve, the posterior tibial nerve is little difficult to block by landmark technique, because the most important landmark to block while giving a posterior tibial nerve block is palpation of the posterior tibial artery. Sometimes it is very difficult to palpate the posterior tibial artery. So in a study, they have shown that if we mark the posterior most part of the Achilles tendon and the medial posterior most part of the medial malleolus, if we draw a line and the midpoint corresponds to majority of location of the posterior tibial nerve. So if you can't palpate the posterior tibial artery, you can mark these landmarks and select the midpoint of this line joining the medial malleolus and the posterior part of the Achilles tendon. We can puncture the flexor retinaculum, aspirate, and give around 4 to 5 ml of local anesthetic to block the posterior tibial nerve. For the sural nerve, we just have to give a subcutaneous infiltration above the lateral malleolus. So these are the landmark guided ankle block. Coming to the PNS response of the nerves around the ankle. So this is the posterior tibial nerve response which we get. As I said, first we palpate for the posterior tibial artery, and just posterior to that will be the posterior tibial nerve. And we get the plantar flexion, and this is an ideal response of the posterior tibial nerve. Coming to the superficial peroneal nerve. So, as I said previously, this superficial peroneal nerve will give a nerve supplied to the peroneus longus and the peroneus brevis. Hence, stimulation of the superficial peroneal nerve will cause eversion of the foot. Just let me get back. So this is the eversion of the foot. So this is the superficial peroneal nerve response. Coming to the deep peroneal nerve, I told you previously that it supplies the extensor digitorum brevis, which will help in extension of the great toe. So this is an ideal response which we can expect by when we are giving a deep peroneal nerve block by PNS technique. For completion, as I discussed earlier, a saphenous nerve block can be anesthetized by just giving a subcutaneous infiltration just above the medial malleolus along this line. And for the sural nerve, from the lateral malleolus, just along a subcutaneous infiltration, joining up to the Achilles tendon. So this completes the ankle block. So the choice of local anesthetic, 0.25% tropiacan or bupivacaine can be used because these are smaller nerves. With this concentration, we can still anesthetize these nerves. Tibial nerve being the biggest and the thickest of all these nerves, we have to give around 5 to 7 ml for a successful tibial nerve. And rest of the nerves, we can give around 3 to 4 ml to give the to complete the block. So thank you once again. You can use this QR code and register yourself for the offline workshop which we are conducting at Surat. Thank you once again.
Thank you, Anil. Very nice and brief view, and congratulate you for that. We already crossed 402 views, so 500 views across here, this short period. And even despite the fact that we actually got the cricket final today, World Cup final. I don't know who is batting and who is bowling. We have not been listening to your lectures. There are no questions on the ankle block. Very simple block, very useful block for any of the forefoot surgeries. I think anybody can do these blocks by landmark technique alone, and it has been done for years now. So we move on to the next thing. So again, so we went from head to brachial plexus to the lumbar, sacral, and other branches till the toe. We'll come back to the abdomen. Some people might be feeling hungry because post lunchtime. So we come to the abdomen with Prasanna. Prasanna, over to you.
Thank you, sir. Am I audible?
Yes, you can start sharing. Yeah. Slideshow. That's
very good afternoon. Very good afternoon to everyone. And as Shiv sir mentioned, we have a very huge compartment in our body, that is the abdomen. And it contains a wide variety of solid as well as hollow viscous, most of which require surgeries varying from laparoscopy to the exploratory laparotomies for their treatment. And that is where the abdominal blocks come into the picture. But before I begin, I would like to thank Dr. Shivkumar Singh sir and the organizers for giving me this opportunity to speak on this topic, which is very close to me, because a lot of surgeries that I give anesthesia for are involving the abdomen. So let us begin with a brief anatomy of the abdomen first. The abdomen mainly consists of 4 muscles on either side of the midline. 3 of these are flat and they cover most of the anterior and lateral wall of the abdomen, starting with the external oblique muscle, which is the outermost, followed by the internal oblique muscle, and the deepest being the transversus abdominis muscle. Now, all these 3 muscles are accompanied by their respective fascia, which lie under the muscle. And it is between these facial planes that the nerve run at various sites. The fourth muscle is the rectus abdominis muscle, which is more centrally placed, and it is covered anteriorly as well as posteriorly by the aponeurosis formed by the intermingling of the remaining three muscles, and it forms a sort of envelope which covers it, which is called the rectus sheath. Coming to the nerve supply, the entire anterior and lateral abdominal wall has a varied nerve supply which comes from as high up as the intercostal nerve from T6 to T11. The lower part gets its supply from the subcostal nerve arising from T12. And then finally, we have the inguinal region, which is supplied by the iliohypogastric and ilioinguinal nerve, which arise from the L1. Now, all these nerves run in the transversus abdominis plane, laterally to medially, and they leave the TA plate at various points to give the anterior cutaneous branches. It is important to know the points where these nerves leave the transversus abdominis plane, because in order to block the anterior cutaneous branches, you have to choose your point of injection very wisely. So for the upper nerve, that is T6, it pierces the it leaves the TA plane to give the anterior cutaneous branch very close to the linea alba, whereas T7 to T9, it leaves the TA plane somewhere close to the anterior axillary line. From T10 to T12, it leaves the plane more laterally, which is somewhere a little ahead of the mid-axillary line. So the higher the incision, the more medial you can come to block the anterior cutaneous nerve, whereas if you have to block the lateral as well as the muscular branches, it is more preferable to choose a point which is more lateral in order to give a complete coverage that is closer to the mid-axillary line. So there are three main blocks which are practiced to block the anterior and lateral abdominal wall. The most popular and common being the transversus abdominis plane block, that is also known as the TAP block. And then we have the ilioinguinal and iliohypogastric nerve, which we can block separately. And then the more central rectus sheath block for the supraumbilical surgery. The TAP block is a very common block, and it can be practiced to provide analgesia right from the upper abdominal surgeries all the way down up to the inguinal region, as well as the panel steel incision of LSES, which is very commonly practiced nowadays. So the transversus abdominis plane lies under the internal oblique fascia and over the transversus abdominis muscle. So the contents of this plane are mainly the nerves which run throughout the plane. Closer to the mid-axillary line, the lateral cutaneous branches are given out and the muscular branches. And as they move more centrally, I explained earlier that they pierce the transversus of internal oblique muscle and give out the anterior cutaneous branches. So there are various zones which you can give the TAP block at. Now, depending upon your site of incision as well as extent of incision, you can choose where to give your TAP block. So for surgeries which have incisions higher up, like a rooftop incision or an exploratory laparotomy or a laparotomy incision for your DU perforation, you can choose to block the subcostal nerve. So you can combine it along with the rectus sheath block, which is given more medially. And then you can choose to block the lower subcostal nerve and the anterior axillary line, since the anterior cutaneous nerves are more important to block rather than the lateral one. But for surgeries which have more extensive incisions, which go more towards the lateral walls, you can choose to block at the lateral in the lateral plane. So you can choose a point either just below the costal margin, or at a midpoint between the costal margin and the iliac crest, or at a point just above the iliac crest. So any of these points can be chosen depending upon the site of your incision to give your tab block. Then the posterior tab block is performed in the triangle of Petit. So I will be speaking about that in detail. And finally, the ilioinguinal and iliohypogastric nerve, which can be performed by two different methods, which I will be speaking in detail about later as well. So let us begin with the classic tab block or the posterior tab block. This is performed posteriorly. It has the advantage of giving you a more extensive coverage, and sometimes, in fact, the coverage because of the spread of LA can be comparable to the quadratus lumborum block as well. So for this, the landmarks are anteriorly. It is this triangle of Petit is covered by the external oblique muscle. Posteriorly, it is lined by the latissimus dorsi, and inferiorly by the iliac crest. So it forms a kind of triangular gap in between where you can feel the loss of resistance and perform your block. So since this is a more posterior block, you will have to position the patient accordingly. So either give a slight contralateral tilt to your patient by keeping a sandbag under the buttock, or you can tilt the table, or you can perform this in the lateral position as well. The only difference between a classical tab block and the posterior tab block is that since the external oblique muscle is deficient here, so you will not feel two pops here, but you will only feel a single loss of resistance and a single pop. So after feeling that single pop, you can inject up to 15 to 20 ml of drug here after aspiration, and to rule out any entry into blood vessels, and you will get a beautiful block. Coming to the anterior block, because of the inconvenience of positioning and pairing of the upper nerves in the posterior block, anterior blocks are preferred nowadays. These can be performed with a patient in supine position, so it is more convenient. So we can have a look at what layers you will be passing when you are performing the tab block. So you first need to pierce the skin and subcutaneous tissue, followed by the external oblique muscle. And then you encounter the external oblique fascia. And this is the level at which you will feel your first resistance or bounce, as we call it. So once you feel the resistance on applying a little pressure, you feel the loss of resistance, which is the first pop. And then you can go to the internal oblique, followed by the internal oblique fascia. And after piercing the internal oblique fascia, you will be in the transversus abdominis plane, where you find all the nerves running along with their blood vessels. So the technique is, as I had said, you pierce. You need to have a blunt needle for this, since feeling the loss of resistance with a sharp needle is slightly more difficult. So you can either use the commercially available loss of resistance needle, you can use your PNS needle, and if not, you can just take a normal simple needle and blunt it by just hitting it against a hard surface like your sterilized bowls or the things that you have in your block kit. So after blunting your needle and locating your landmark, you can pierce through the skin with slight pressure. At this point, you have to be a little careful because of something that we call the cushioning effect. Now, because your needle is blunted, it takes a lot of pressure to pierce through the skin. And in that pressure, you might bypass the external oblique aponeurosis as well. So you have to pierce the skin and then withdraw your needle slightly so that it comes to lie in the subcutaneous tissue before you go ahead and start to perform your block. And then you pierce the external oblique muscle. At the external oblique fascia, you feel your first bounce and pop. Then you advance further through the internal oblique muscle, and at the internal oblique fascia, you will feel your second bounce and pop. So if you see it in a cross section, this is how your needle will be passing through all the layers. And then at the transversus abdominis plane, you can aspirate and give 15 to 20 ml of your drug in small aliquots of 5 ml each, aspirating each time, just to make sure that you have not entered a blood vessel. And to confirm that you are in the facial plane, you can just disconnect your syringe from the needle and look for a free backflow of the local anesthesia. So if you get a free backflow, you can be sure that you are in a facial plane and not giving the drug intramuscularly. This is a short video. So in this, we can see Dr. Kala ma'am performing the subcostal tableau. This is just to give you an idea of how you can feel the bounce and pop. It can be observed even by a person who is observing from outside. So she has blunted the needle and is entering the skin at an angle to prevent the cushioning effect. The needle is left open so that if she encounters any blood vessel, there will be a backflow of blood, so she can change the position. This is the first bounce. And that is the first loss of resistance. She advances it further, second bounce and second loss of resistance. This is how you can actually feel the loss of resistance suddenly when you blunt the needle. Aspirate, and you can inject 15 to 20 ml of drug there. In between, you can disconnect the syringe to look for backflow. And once you are sure, you can inject the remaining drug. So what can go wrong here while doing these blocks? So firstly, because of experience, you need to keep performing these blocks to feel the perfect loss of resistance, or pop as we call it. So if you cannot feel it at one go, you can try changing the angle of the needle so that you can feel those pops correctly, and then go ahead and do your block. Secondly, if you might be intramuscular, this can be checked by disconnecting the syringe at every 5 ml. If there is a backflow, you can be sure that you are in the facial plane. If you are injecting the drug intramuscularly, then there will be no backflow of drug. Now, since most of these blocks are facial plane blocks, they involve large volumes of drug to cover a larger surface, a larger area, and larger number of nerves. So as you can observe, most of these blocks require around 15 to 20 ml of drug, and many a times when the incision extends to either side of the midline, you might need to give them bilaterally. So you have to keep in mind the toxic limits of the drug that you are using, the weight of the patient. So the simplest thing you can do is calculate your toxic limit, toxic dose ahead of performing your block, and then you can assess your volume and then divide the volume between the number of points that you want to perform your block. And finally, if you are in the wrong plane, then there will be no effect. It is shown here in the diagram. Actually, the nerves are supposed to be below the green lines. By mistake, I have put them above the green line. But see, if you pierce through the external oblique fascia and mistakenly, because of the cushioning effect or whatever, you have not been able to pierce the internal oblique fascia, you will be depositing the drug between the internal oblique and the internal oblique fascia. So you might get a backflow and you might feel everything is fine, but the nerves will actually be between the transversus abdominis and the fascia. So you will not be anesthetizing the nerves at all. So this is something you need to be careful of. If you have a PNS at hand or a USG machine at your disposal, you can always confirm whether your drug has been placed in the correct plane. Now coming to the ilioinguinal and iliohypogastric nerve block. Both these nerves arise from the L1 branch, and they traverse in the transversus abdominis plane initially, and here somewhere near the anterior superior iliac spine, they give out a lateral cutaneous branch to the gluteal region as well. Then the IIN pierces the internal oblique a little above the iliac crest to continue between the two oblique muscles, accompanying the spermatic cord and round ligament of the uterus, whereas the iliohypogastric nerve continues in the transversus abdominis plane and finally pierces the gives the anterior cutaneous branch at the suprapubic region. So there are two ways in which you can perform this block. First is the classic method. In this, the point of injection is selected at 2 centimeters medial and 2 centimeters scapholar to the anterior superior iliac spine. So if you can see the diagram below, the layers pierced are the skin and subcutaneous tissue first, then the external oblique muscle. And there you feel the first bounce over the external oblique aponeurosis. As I had mentioned in the earlier slide, above the anterior superior iliac spine, the ilioinguinal nerve pierces the internal oblique and comes to lie between the two obliques. So at this point, which is medial to the anterior superior iliac spine, the ilioinguinal nerve lies between the two oblique muscles. So once you are in this plane, after the first pop, you are supposed to inject around 5 to 10 ml of local anesthesia for anesthetizing the ilioinguinal nerve. After doing that, you can further progress your needle, feel the second bounce at the internal oblique aponeurosis and a second pop there, and inject 5 to 10 ml for your iliohypogastric nerve. So if you see it in a cross section, this is after piercing the skin and subcut. You feel the first bounce after the external oblique and the first pop from the external oblique fascia, 5 to 10 ml there for the ilioinguinal. Then you further progress the needle, pierce the internal oblique fascia and give 5 to 10 ml there for the iliohypogastric. The second method to perform this block was based on a study performed by Eisenberger. So this point is also called the Eisenberger point. This point lies 5 centimeters above and 5 centimeters lateral to the anterior superior iliac spine. Or this can also be the point where you perform your lower tab block. So it has been shown by studies that at this point, both the nerves, the ilioinguinal as well as the iliohypogastric, lie in the transversus abdominis plane. So you can use this point as a single point and feel the loss of resistance just like your classic tab block. 2 bounces and 2 pops, and then you can give 15 to 20 ml of drug at just a single point to block both the nerves together. This is a video by Shiv sir, where he is using the PNS to actually demonstrate the twitches when both these nerves are stimulated. So he has chosen the point 5 centimeter above, 5 centimeter lateral, and here he pierces the skin. Here he feels the first loss of resistance, and once he progresses further with the second loss of resistance, you can see the contractions of the lower abdominal muscles. Once these contractions are seen, you can easily say that you are in the right plane. You can aspirate and inject. So once he has injected, you can automatically see those twitches disappearing. So as with all other blocks, what can go wrong here is you fail to feel the pops and the bounces. So that comes with practice. Initially, you can slightly withdraw the needle and change the angle to caudad or cephalad as you are comfortable, and you can go ahead and perform it again. There is a chance of intramuscular injections since they are all different planes between flat muscles, and therefore you need to regularly disconnect your syringe from the needle to look for a backflow. LA toxicity, because again these are high volume blocks and there is a chance that if it goes intravascularly, you might face LA toxicity. So availability of intralipid in your setup is very, very important. And if you are in the wrong plane, again, there will be no effect. Finally, coming to the rectus sheath block. This block is more important for midline incisions and mainly supraumbilical incisions, mainly because of the anatomy of the rectus sheath. Now, the rectus abdominis muscle is centrally placed. It extends all the way from around T6 level all the way to the pubic symphysis. But the rectus sheath has a different anatomy at every level. So above the costal margin, it is formed entirely by the aponeurosis of the external oblique muscle, and posteriorly there is no sheath present. It is covered by the ribs as well as the intercostal muscles. Now, between the costal margin and the arcuate line, you can have the anterior rectus sheath, which is formed by the external oblique and a part of the internal oblique aponeurosis. And the posterior rectus sheath is formed by a part of the internal oblique and transversus abdominis aponeurosis. So they kind of form an envelope around the rectus abdominis muscle. And then below the arcuate line, all the three aponeuroses traverse ahead of the muscle, again making the rectus sheath deficient on the posterior side, and it is directly in contact with the fascia transversalis. So the landmarks for this block can be either, you can perform either a 2-point block on either side. This block needs to be performed on both sides to be more effective. And so you can either choose to give it at 2 points or you can choose the 4-quadrant rectus sheath block. So if you are choosing to give it at 2 points, you need to choose the midpoint between the xiphisternum and the umbilicus. And then at that point, go 5 centimeter lateral on either side and perform the block. Whereas if you're going for the 4 quadrant, you divide the same area into 4 different quadrants. And at the midpoint of each quadrant, 5 centimeters from the midline, you need to perform the block. And you have to divide your dose accordingly if you're choosing to do the 2 or the 4 quadrant method. The technique here is slightly different from the tab block because here the nerves travel in the space between the rectus abdominis and the posterior rectus sheath. So when you pierce the skin and subcutaneous tissue, and you will feel the first resistance or bounce over the anterior rectus sheath. You once you pierce that and feel the first pop, you go ahead, go through the rectus abdominis muscle and feel the second bounce over the posterior rectus sheath. So the difference here is you do not have to perform the second pop. Since your nerves are lying in this plane, you have to deposit the local anesthetic agent around 15 to 20 ml in this plane. And if you perform the pop, you will be bypassing this plane and going into the abdominal cavity. So if you can see the spread of the local anesthetic agent, it is more central. So if your incisions are extending more laterally, like the rooftop incisions, etc., so just a rectus sheath block will not be sufficient, and you will need to combine it with a subcostal tab block. So for more midline incisions, this block is very, very effective, and it needs to be performed on both sides. So this is a small video. This was performed by Dr. Akhilesh in RAD, Mumbai. So that he has pierced the skin. He felt the first pop, and now he's feeling the second bounce. He hasn't done the second pop. And he connects his syringe here, aspirates, injects around 5 to 10 ml. And just to check whether he is in the right plane, he will disconnect his syringe. And this is how you get the backflow. If you are in the facial plane, you will get a beautiful backflow. And if you are intramuscularly, you will not see this backflow of local anesthetic agent. So once again, as with all other abdominal blocks, an intramuscular injection will not give you a backflow. So if there is no backflow, it is always advisable to remove your syringe and start performing the block once again. LA toxicity, I cannot say this enough, but this is a real threat in these blocks since these are large, high volume blocks. So you can choose the concentration to be on the lower side. Like there are studies that even 0.1%, 0.125% of bupivacaine, 0.2% of ropivacaine give adequate analgesia in these blocks. And so you need not take high concentrations. You can choose to increase the volume so that you can divide the volume equally among the number of blocks that you want to perform. And in the rectus sheath block, especially if you are in the wrong plane, we are so used to performing tap blocks that we feel 2 bounces, 2 pops. And here, if you are going to do the second pop, you will be in the wrong plane. All the drugs will be deposited in the extraperitoneal space where it will not give you any effect at all. So be very careful that you don't perform the second pop. And after the second bounce, you will have to inject 15 to 20 ml of drug. So the take-home message here is that these blocks are very simple to perform. They require very limited resources. You can just have a syringe, needle, local anesthesia. And if you're good with your landmarks, then these blocks can be performed anywhere. The only thing you need to be careful of is being in the right plane. So you need to practice more and more often to feel the pops and bounces correctly. And of course, local anesthesia toxicity. So you have to be very cautious, look out for symptoms, and always have intralipid at hand for rescuing you. Thank you. And we are open for questions.
Absolutely crystal clear, Prasanna, I think, and there aren't any question. There was actually a question, but I've answered it about the use of PNS for the tap block and a watt current. So you don't actually have to be very precise. It's not like giving a nerve block or a plexus block where you need to be 0.4, 0.5 milliamps. Yeah, you get it disappears at 0.7 point, that's fine. We want anywhere between 0.5 to 1 milliamp, you're fine to actually just inject. You are in the right plane when you do that. Contractions are due to stimulation of nerve or direct muscle, and that is absolutely wrong. You can try it. You just put a needle into a muscle and keep increasing current, and you will find that you will only get muscle contraction once you're reaching almost 4 to 5 milliamps. Direct muscle contraction, unless you are actually next to a muscular branch, which you can actually contract with a similar kind of current, direct muscle contraction does not occur unless you actually apply a very high current. Okay, so that was the other question. So you will not get a direct muscle contraction. You can put it, just go stab your needle into your cordyceps. Okay, yeah. Well, you can be lucky that you could actually be next to a muscular branch, but try it and keep increasing. You will not get contraction till you are almost 5 milliamps. Okay, so muscles require much higher current to have direct stimulation. Okay, I think if there are no questions or if anybody has got any comments, you can actually come forward. Otherwise, we will move on to the last lecture of the day. So from the abdominal blocks, I think there are like quadratus lumborum blocks and things like that, but these are not PNS guided blocks. So we didn't actually go to that. But the posterior tab block, which I was actually demonstrating as a PNS guided block, that is actually a lateral quadratus lumborum block, and it works excellently. You don't actually have to do any other blocks for that. If you do that block, you deposit 15-20 mL of local anesthetic, you get excellent coverage of the abdomen. So we move on to the the chest wall blocks. So chest wall blocks from anterior, medial, lateral. There are quite a few of them. And again, these were going to be two different lectures, but Akhilesh will actually cover both the anterior and lateral as well as the posterior chest wall blocks. Over to you, Akhilesh.
So thank you, sir. I'll be sharing my screen now.
You can. I can't say it yet.
Yes.
Yep, you're on. Go on to the slideshow.
Yes.
And you're there. Yep. Go for it.
Yeah, so it's cricket day today, and I think I opened the batting today, and probably I'll be facing the last ball as well. So we'll be going to the thoracic nerve blocks from the abdominal nerve blocks now. So it has been quite some time that thoracic nerve blocks are in place now. Their role is like established. But even today, the thoracic nerve blocks remain an enigma to a lot of anesthesiologists. It's like a case that everyone wants them, everyone wants their patient to be totally pain free, but not everyone knows how to administer them successfully. Or maybe they are apprehensive about administering them. Now, the reason for this can be maybe poor understanding of the thoracic anatomy, or maybe a fear of a lot of vital structures that surround the block sites. That what if I go too much in, or what happens what happens if I hit this structure, or if I hit pleura, or what can happen. So, welcome to the world of thoracic nerve blocks and their anatomical basis. So we shall cover the thoracic nerve blocks under the three anatomical regions. The anterolateral chest wall blocks, which shall comprise of PEX blocks 1 and 2, and the serratus anterior plane blocks. The posterior chest wall blocks, that is the thoracic paravertebral blocks, and the erector spinae plane block. And at the end, we shall finish it off with a brief descriptions of the anteromedial chest wall blocks. So the framework for today's presentation will be on the lines of indication, anatomy, origin, and their relationships. What are the landmarks? What exactly lies under the skin? A brief explanation of the procedure, causes of failure, complications. What are the different structures that a needle can hit if we attempt these blocks, and how to avoid, prevent these complications. Now, many a time we often talk of pain. We think about the incision. We think about the patterns of cutaneous innervations. What we don't think is what is underlying this skin, or where exactly is the surgery happening? What are the underlying structures that are also injured? The pain from trauma to muscles, ligaments, and joints and bones is just as significant. And that is where the Hilton's law comes into play. That is, the nerve supplying a joint also supplies both the muscles that move the joint and skin covering the articular insertion. So, nerves which were regarded as purely motor, may actually be involved in pain transmission. We should not only look at the cutaneous innervation, but also the underlying structures that are operated upon, and accordingly go for nerve blocks. So, one of the cornerstone nerve for the management of pain or cutaneous distribution is the intercostal nerves, and its anatomy is as something like this: that the spinal nerve root exits the intervertebral foramen, and then it divides into the anterior and the ventral rami. The ventral and the dorsal rami, and the dorsal rami supplies the back. The ventral rami continues as the intercostal nerve running between the innermost and the inner intercostal muscles. At the mid-axillary line, it gives out a lateral cutaneous branch that pierces the internal and external intercostals and supplies the skin on the lateral chest wall. Multiple branches from the intercostal nerves here innervate the ribs and the muscle layers, and the intercostal nerve in the anterior cutaneous nerve, which supplies the anteromedial chest wall, that is this segment. Going on to the anterolateral chest wall blocks and their applied anatomy, we shall be covering the pecs 1, 2, and the serratus anterior plane blocks. The common indications for these blocks include the breast surgeries, pacemaker insertions, minimally invasive cardiac surgeries, sternotomies, anterior thoracotomies, and video-assisted thoracic surgeries. Now, this is the cross-section of thorax, and the encircled area, that is the anterior and the anterolateral segment, is our area of interest in the current segment. Now, in this part, you can see that there is a sheet-like muscle, which is the pectoralis major, which kind of forms the roof of the anterior thoracic wall. Underneath this is the pectoralis minor, which is a slightly slender muscle. And between them is the plane where we can deposit the drug for pectoralis 1 block, apex 1 block. And then as we move laterally, underneath the pectoralis minor, we can see the serratus anterior, which is purple in color. And here we deposit the drug to achieve pex 2 block, right? Now, if we go to the individual muscles, we can see that pectoralis major is a kind of sheet-like muscle. It forms the roof of the anterior thoracic wall. It takes origin from the medial half of the clavicle, anterior surface of the sternum, medial part of the 2nd to 6th costal cartilages, and aponeurosis of the external oblique. So these are the origin points, and it gets insertion at the lateral tip of the intertubercular sulcus. Underneath is a slender pectoralis minor muscle, which originates from the 3rd, 4th, and the 5th rib near the costal cartilage, and is inserted into the medial border and upper surface of the coracoid process. Now, this is an interesting figure, because if you see the sagittal section at the axilla and you concentrate on the anterior part of this sagittal section, you can see that this is the clavicle, this is the subclavius muscle, this is the pectoralis major, and this is the clavipectoral fascia that encircles the pectoralis minor. Now you can see, or if you just go back into the timeline to your MBBS days, in the anatomy lectures, we always had a code as to what are the structures that pierce the clavipectoral fascia. And these structures we remembered as the mnemonic TALC, that is thoracoacromial artery, the lateral pectoral nerve, and the cephalic vein, right? So these are important structures. One, because the lateral pectoral nerves, they supply the pectoralis major muscle. This is the thoracoacromial artery, which is from the first part of the axillary artery, arises from the first part of the axillary artery. And this is important in 2 aspects. One, it forms an important landmark in the sonoanatomy while we are administering the PEX block via ultrasound guided PEX block. It lies between the PEX major and the pectoralis major and the pectoralis minor. Secondly, if we happen to hit this thoracoacromial artery, it can be a source of hematoma. And thirdly, we can always, there's a chance that we inject our drug inside these vessels, that is the cephalic vein and the thoracoacromial vessels, and this can result into local anesthetic toxicity. Now, even if the medial and the lateral pectoral nerves, they arise from two different roots. The lateral pectoral nerve is the bigger one, and it rises from the C5, 6, 7, and the medial pectoral nerve arises from C8 to T1. But what they are having under the pectoralis major is a loop of communication. So they, both of them, kind of keep communicating with each other, supplying the pectoralis major muscle. So pectoralis major is being supplied by the whole brachial plexus from C5 to T1. Along with it, under the pectoralis major lies the axillary vein and the first part of axillary artery. Now in this muscle, in this diagram, you can see that the pectoralis major, the sheet has been kind of removed. You can see this is the pectoralis minor, and this is dividing the axillary artery into three segments. The first part, second behind the minor, and the third part. This is the axillary vein, and this is the thoracoacromial artery that I had mentioned previously. Now, these are the relationships that we were all mentioning earlier. The pectoralis major, pectoralis minor, and sandwiched between them are the pectoral nerves. And in between the nerves is the very important thoracoacromial artery. Underneath the pectoralis minor is the serratus anterior. Mind you, the landmark for this block is the third rib. So we are seeing everything, all the diagrams regarding pectoralis blocks, pex blocks are at the level of third rib, right? So we can see this is the pectoralis minor, underneath is the serratus anterior. And if we deposit the drug between the pex minor and serratus anterior, we can see we can administer the pex 2 block. So once at the level of third rib, we go perpendicular to the skin with a nerve block needle or a blunted normal needle. We traverse through the skin, subcutaneous tissue, and the prepectoral fascia. Now, this is the prepectoral fascia that will give you the first pop. And the first pop, with the first pop, you will land up between the pectoralis major and the pectoralis minor. And you can administer at the level of third rib local anesthetic, which will anesthetize the pectoral nerves and the cutaneous nerves that are traversing through this plane. You go further in and you can feel the pop of the interpectoralis fascia. Now this is above the pectoralis minor, and with this you will land up after crossing the minor muscle. You will land up between the pectoralis minor and the serratus anterior and can administer the pex 2 block. The common complications that can happen are the intravascular injections, and if you go too deep, it can result in pneumothorax. So we can prevent these complications by one, identifying the landmarks, identifying the proper loss of resistance, bounce, and pop, aspirating prior to injecting, and avoid going too deep. This is the PEX one that I was talking about, where you get the first pop of the prepectoral fascia and you end up between the pectoralis major and minor. This is the PEX 2 block where you get two pops of the prepectoral fascia and the interpectoralis fascia, and you can deposit the drug between the pectoralis minor and serratus anterior at the level of third rib. Next, we move on to the serratus anterior plane block. Now, serratus anterior is a fan-shaped muscle and takes its origin from the first to the 8th ribs on the lateral chest wall. It is inserted on the scapula, has its motor supply from the long thoracic nerve with root value of C5, 6, 7, and a sensory supply of lateral cutaneous nerve, 2nd to 5th. Now, like in Peck's block, we had the shown anatomical landmark of thoracoacromial artery. In this case, we have the landmark of thoracodorsal artery, right? And in terms of ribs and mid-axillary line, we have the landmark at the junction of the mid-axillary line and the fifth rib. In this figure, you can see that this is the serratus anterior muscle. This is the long thoracic nerve, which is traveling on the belly of the serratus anterior. And these are the cutaneous nerves, the lateral cutaneous nerves, which are supplying this overlying skin. Now, again, you can see this is the all-important vessel that provides us with this one anatomical landmark and the risk of hematoma or local anesthetic toxicity injection. And this is the thoracodorsal artery, which lies between the latissimus dorsi and the serratus anterior at the level of the fifth rib. As I mentioned previously, for the SAP block, when we are going landmark guided, the main landmark is the junction of the fifth rib and the mid-axillary line. And the structures traversed are the skin, subcutaneous tissue, latissimus dorsi, and the serratus anterior. And the causes of failure for this block are mainly due to the poor identification of plane and incorrect plane. The common complications that can happen are intravascular injections and pneumothorax. Now see, in this landmark guided method, what we do is, at the level of fifth rib in the mid-axillary line, we go perpendicular to the skin and we go straight and hit the fifth rib. At this point, we just withdraw our needle by a millimeter or two and we deposit the drugs under the belly of serratus anterior. This is, in other words, this is the deeper block or the SAP block deeper version. There is another version, which is the superficial version, in which we can go with the help of a PNS, we can identify this plane between the latissimus dorsi and serratus anterior. And what we are targeting in this superficial version is we are trying to stimulate the long thoracic nerve. So once we are entering this, So what can happen is when we are using the PNS and trying to stimulate the long thoracic nerve at the landmark that I mentioned, we see the contractions of serratus anterior. But sometimes it is possible that we do not see the contraction. Now, what can be the cause of this failure? The cause is that the course of this nerve can be variable and it can be placed anteriorly or posteriorly. And as a result of which, we might have to search the nerve on the landmark either anteriorly or posteriorly, both ways, depending where we get it. Another cause of failure is the incorrect plane, that we have gone too deep or we are lying still superficial and we haven't reached the plane between the latissimus dorsi and the serratus anterior. And the common complications that can happen are the intravascular injections, pneumothorax, and winging of scapula. This is the diagram. I had explained it previously as well. Next, we move on to the posterior chest wall blocks and their applied anatomy. And the blocks that we will be covering it shall include the thoracic paravertebral blocks and the erector spinae plane blocks. Now, the common indications for which these blocks are used include the breast surgery, in which we should cover from C7 to T6. The hepatic surgery, where we might have to block at multiple levels. The rib fractures, where that particular dermatome needs to be blocked. Then again, nephrectomy, where T8 to 12 we have to block, and again, multiple level of blocks might need to be given. Then thoracotomy or minimally invasive cardiac surgery, we can use these blocks. Going on to the thoracic paravertebral space anatomy. Now, thoracic paravertebral space is a wedge-shaped space, right? The contents of this wedge-shaped space are spinal nerves, sympathetic chain, intercostal vessels, and fat. And it is triangular, wedge-shaped, and the anterolateral border is formed by the pleura and the lungs. The medial border is formed by the vertebral body, intervertebral disc, and intervertebral foramen. And the posterior border is formed by the superior costotransverse ligament and the ribs. A few authors also say that the paravertebral space is divided into the anterior and posterior segments. However, they have failed to explain as to why this division is or what purpose this division serves. Now, going on to the landmarks, if you see, these are the landmarks. We are the circles are the spinous processes of the corresponding vertebra, and around 2.5 to 3 centimeter laterally is the point where if one inserts the needle perpendicular to the skin, one is likely to hit the transverse process. Now, in loss of resistance method, a person may use an epidural needle and advances it perpendicular to the skin until it contacts with the transverse process of the corresponding vertebrae. He now walks off inferior laterally while advancing the needle, but it should be borne in mind that the maximum depth at which the person should go should be 1 to 1.5 centimeters. Many anesthesiologists prefer to put a mark, or with their finger they tend to keep a guard as to up to what depth have they gone. And once the costotransverse ligament is crossed, there is a loss of resistance that is felt. This is the place where you have to deposit your local anesthetic. In case you want to put in a catheter, you might need to hydrodissect it, inject some amount of saline, and then place the catheter inside. If you are using a block needle and a peripheral nerve stimulator, then in that case, intercostal muscle contraction is what we are looking for. Again, these are the landmarks and the wedge-shaped space. Mechanism of action in paravertebral block has been explained in 3 ways. One is you deposit the local anesthetic in the paravertebral space, and the content of the paravertebral space is the spinal nerve. So the local anesthetic directly acts on the spinal nerve. Second, the local anesthetic drug may move laterally along the intercostal nerve, which may explain its action on the anterior chest wall and the lateral chest wall. Another one explanation is that instead of the drug moving laterally, now the drug has moved medially and has extended through the intervertebral foramina. Now, what has resulted? Both the dorsal and the ventral rami have been blocked at this place itself. Again, it explains the anterior, lateral, and the posterior, all the walls of the thorax being blocked adequately. The complications that can happen, as you had seen in this diagram, that this paravertebral space is very closely related to the epidural space, to the lung and pleura, and the sympathetic chain, which is one of the content. And if you exceed that 1 to 1.5 centimeter mark, you are likely to either enter the pleura, resulting in pneumothorax. Then you can your injection may result in epidural placement. There are blood vessels which can result in intravascular administration of the drug, and because of sympathetic chain block, it can result into hypotension and bradycardia. Now, while I was reading one of the article regarding, it was basically an anatomy journal, what they had suggested was that people who had actually given this paravertebral block had the complication rate of with regard to pneumothorax was around 1 to 1.5%. They had examined a number of patients, and the reason for that, they explained that your needle pierces the pleura, and then you don't actually appreciate many times that you have pierced the pleura, and you end up giving the local anesthetic intrapleurally. That itself provides analgesia, and you come out. So a single rent often doesn't kind of create the damaging pneumothorax, but none of the other journals or other articles support this view. So it was just one of the bits of information that I wanted to share with regard to this. The next one is the erector spinae plane block. Now, the best part of erector spinae plane block is that erector spinae again is not like a single muscle. It is like a band of multiple muscles that are placed over the transverse process along the entire length of the thoracolumbar spine, and they create a plane. Now, what happens is, in this case, we are targeting the dorsal and the ventral rami. The landmark in this erector spinae plane block is also exactly the same as the paravertebral block, that is 2.5 to 3 centimeter lateral to the corresponding spine. So previously also it was the same, now also it's the same. But the only difference is, in the paravertebral block, what we were doing is we were advancing the needle and directing it inferolaterally. In this case, what we do is we do not move the needle, we just withdraw the needle by a millimeter, and then we deposit the drug just over the transverse process and let the erector spinae band of muscle do the rest of the job. Now, volume of around 30 to 40 mils will result in a spread of 6 to 8 segments with the help of this band-like muscle. But again, if you are not able to identify the correct landmarks, there is always a chance that you can enter the pleura, enter the epidural space, and affect the sympathetic chain. The LA spread in the erector spinae plane block, as I mentioned, the erector spinae muscle extends along the entire length of the thoracolumbar spine, thus creating a plane, and permits the extensive craniocaudal spread of local anesthetic to cover multiple dermatome levels. Local anesthetic is deposited. The target is that the local anesthetic should be deposited deep to the erector spinae muscle and closer to the costotransverse foramen. But despite identifying and depositing, you might still encounter failure. So the two causes of failure are: one, you have injected the drug too medially, so there is a late onset, and this is kind of a retrolaminar block happening. Another one is there is a two lateral injection that you have performed beyond the 3 centimeter margin, and the external and the internal intercostal muscles are preventing the local anesthetic spread. Again, the complications are almost the same as that of the paravertebral block, that is the pneumothorax, epidural placement, intravascular injections, and because of sympathetic chain, local anesthetic acting on the sympathetic chain, hypotension, and bradycardia. Going on to the last segment of the chest wall blocks, the anteromedial chest wall blocks. Now, if we recall, the intercostal nerve terminates as the anterior cutaneous nerve, which travels to the parasternal region and then crosses the transverse thoracic muscle and the internal intercostal muscle and the pectoralis major muscle. So it is crossing, the internal intercostal muscle travels between the transverse thoracic muscle and the internal intercostal muscle and crosses the internal intercostal muscle and the pectoralis major muscle. Now, because of these three muscles that are present there, two facial planes have been created, one between the sternocostalis and the intercostal muscle, and another one between the pectoralis major and the intercostal muscle. Now, it is very easy to say that you just go in and deposit the drug between the two, but these are very, very thin muscles at this point, and the loss of resistance may not work there, and you might just need ultrasound for very, very accurate placement of the local anesthetic. But we do have parasternal infiltrations, which I shall be discussing in the next slide. And so the indications of these blocks are the cardiac surgery, the breast surgery, especially if there is a medial extension of the incision. Again, the nerve that needs to be blocked is the anterior cutaneous nerve. And a point that I want to highlight is that this region is very vascular, and the blood vessels that are associated with this anterior cutaneous nerve are the internal mammary vessels. Now, as a result of this high vascularity of the parasternal region, there is an increased absorption of the local anesthetic if it gets deposited at this spot, which can result into systemic toxicity, sometimes even when the artery or the vein has not been injured, still the local anesthetic can get absorbed. Secondly, you can obviously always injure the blood vessels that are present in that plane, that is between the sternocostallis and the internal intercostal muscles. So what we do in parasternal infiltration, because suppose we don't have a USG machine, what do we do next? Do we leave the patient in pain? No. So what do? We just go 3 centimeters lateral to the sternal border and any level that we wish to. So along the sternal border, we might have to give the local anesthetic at multiple levels. So we go 3 centimeters lateral to the sternal border. We hit the rib at that very level, and then we inject the local anesthetic. All right. So again, the landmarks in this parasternal infiltration blocks are the sternal border and the ribs, and the complications that can occur are pneumothorax, intravascular injections, and hematoma formation. To summarize, chest wall blocks, landmark based and PNS guided, are safe and easy, provided we know our anatomy well and the nerves that are involved and need to be targeted. Posterior chest wall blocks, thoracic paravertebral blocks, and erector spinae plane blocks have the facility that they permit extensive spread with a limited amount of local anesthetic, thereby covering multiple spinal levels. Next is that anterolateral chest wall blocks, they block the lateral cutaneous nerve and miss the anterior cutaneous nerve. And lastly, the anteromedial chest wall blocks for sternal plane we should give and supplement with anterolateral chest wall blocks. Thank you.
Thank you, Akhilesh. I think, again, a wonderful lecture. Very crisp, clear, very precise. I think people are busy watching the cricket, so there isn't very many questions on these blocks. And I think you already stressed that these blocks are not very difficult to actually perform. And important thing is to actually know what the surgical anatomy is going to be, especially the breast surgeries are so very different, and the incision can be at different places. So speaking to the surgeon and finding out what is their incision going to be, what is the extent of the surgery, and then accordingly you can start giving the blocks. Over the years, I've seen that now most of the surgeries you can actually do with just 2 blocks. So you do a serratus anterior plane block and do your parasternal block, which is simple. You go 3 centimeters, like said, lateral to the sternal border. You put if you're doing with the ultrasound, you put the ultrasound there and just inject over the ribs. Or even if you don't have ultrasound, I've done it blindly as well. Just hit the rib and just go into the same plane with a long needle. You're very unlikely to actually go deep, but you can. It's not that. I think in patients, who are lean or cachectic patients, cancer patients can be cachectic. In those patients, you can't actually go, but just if you remain very close to the skin and ribs, then you won't cause a problem. But analgesia is excellent. So easy blocks to do. Erector spinae block, again, you don't need an ultrasound block. I have done it in patients on the ward with rib fractures. Just took a needle and local anesthetic, hit the transverse process, and just inject at multiple levels. Each 20 mL will cover almost 4 to 5 segments. So increasing the volume does not actually increase the spread. So either you just use 10 at every 2 or 3 segments, or if you want to cover more segments and you want a single injection, then just use 20 mL, no more than that. And you're right. I mean, don't worry with paravertebral blocks. Paravertebral blocks are actually excellent. You can give them, and even if you go into the pleura, single rent, you are doing intrapleural analgesia. And it's a known technique. People were doing the interpleural analgesia before the erector spinal block was discovered or mentioned for the thoracic surgeries or chest wall surgeries. And it's a known signal injection. They were using bigger needles. I mean, all block needles are much smaller and thinner. So the chances of causing pneumothorax is very, very small. I wouldn't worry about that. Okay, Anil, I think, has just put a comment that many of the facial plane landmark or PNS guided blocks are very easy and better than ultrasound. That's actually probably pretty true as well. People get excited with ultrasound block because they could be actually in between the muscle fibers. So you look at the rectospinal muscle, the fibers are running across, and you could be depositing local anesthetic within the muscle and see, oh, beautiful spread. Yes, it will spread along the muscle, and you think that you're given a beautiful block, but it doesn't work. But when you hit the transverse process and inject local anesthetic, it will spread under the muscle and in the right plane. So that's why I think landmark guided blocks work actually extremely well. And I think everybody has appreciated all the presentations today. They've been amazing. Everybody actually done a great job. So I think you can go back to watching cricket, and I'll see you later, everyone.
Thank you, sir.